Thank you all for joining us tonight, and we're live from Miami, Florida, and I want to send a warm welcome to our virtual audience that's out there, and I'd like to also welcome our live panel who's with us tonight. I'm Tom Herzog. I'm a G1 oncologist at the University of Cincinnati, and have the privilege of serving as the GOG Foundation president. Brad, can you introduce yourself?
Yeah, thanks, Tom. This is number 6, guys. This is number 6, and at every highlight reel, we've had new and exciting indications and clinical trials that will lead to indications and evolve the standard of care, which is our mission. So happy to be with you guys today.
Yeah. Thank you, Brad, and thanks for all of you that are joining us tonight. It's been an incredible year in G1 oncology, and in terms of the number of data sets that have come out. We've seen so many positive readouts throughout the course of the last few months, and we're very excited for the program tonight. As a result, we've changed our format a little bit to try to help maneuver through the new data and opportunities for our patients. Rather than simply presenting the data that were presented at key meetings throughout the year, we aim to focus on the discussion to allow our expert panel share their insights and to put this data into clinical context. In other words, we really want to know, does this data change the standard of care? And if so, how does it do that? Our mission on behalf of the GOG Foundation is to transform the standard of care in gynecologic malignancies. And our mission really does represent our patients, and our purpose is to find new cures for cancers we treat and help our patients live stronger and longer lives. One of the biggest components to successfully achieve our mission is you, our GOG sites and colleagues. You're the key component that supports this mission by accruing patients on our trials, and we're very grateful for your support. I want to thank our leadership that's present here today, and all the people that really contribute so much to the knowledge base that we've seen. You'll see many of their names on some of these trials and so forth. I think that having you here in the audience is really special. So thank you. Thanks for your commitment to the foundation, not only today but every day. And I really want to thank all of you for attending today that are out there, and to the entire roster of investigators, which are really key to our whole organization, and for your efforts in helping us transform the standard of care. Brad?
Well, thank you, Tom. For today's highlight reel, the overall objective is to showcase the clinical trials that you've done and that are newsworthy to education and from the major medical meetings in the fall, basically ESMO. So I'd like to look forward to sharing the data with you. We hope as our objective to gain greater competence related to selecting therapies and treatments for women with cervical, endometrial, and ovarian cancer. Number 2, increasing knowledge about current agents and regimens, reviewing key clinical trial data, and looking even at investigational agents in studies that you have the opportunity to enroll to. Our GOG faculty disclosures in compliance with the ACCME regulations, including the GOG Foundation, Inc., provides accreditation for this activity. We're going to ensure that anyone in a position to control the content of this educational activity has disclosed all relevant financial relationships with any commercial interest. All reported conflicts are managed by a designated official to ensure a bias-free presentation. Please see the faculty disclosure for detailed information. So this is CME approved. 2.5 hours will be granted for those who complete the post-meeting survey. Tom, turning it back to you to share a few additional housekeeping notes.
Yeah, thanks, Brad. GOG Foundation would like to thank its commercial supporters for independent medical education support associated with this symposium. I'd like to thank AstraZeneca, GSK, Seagen and Genmab, Immunogen, Genelux, Acrivon, and R-Pharm. So let's get started. Honored to welcome our esteemed course faculty, and it's incredible to be back together. Joining me today as co-moderator, Dr. Brad Monk, along with our presenters and panelists. You all look ready to roll, so this is great. I'd like to thank Angeles Alvarez-Secord for coming all the way from Duke, Rob Coleman, who's at Texas Oncology and the Van Am Group, Bhavna Patori, who's at NYU Langone in New York, Leslie Randall at Virginia Commonwealth, Rithu Salani at UCLA. So you really flew the furthest thing. I have to give you that. And the person who flew the least far, and maybe you took your drone over here, Brian Slomowitz from Mount Sinai Medical Center right here in Miami Beach. So thanks, Brian. We appreciate you being here as well. In order to stay on schedule, we'll be enforcing time limitations for our presentation. I'd also ask you, the live audience, to engage during this session by using the chat feature. The course faculty will be monitoring the chat throughout the session, and we'll really do our best to answer all of the questions that you send in. So please send those questions in. I wish you were here live, and we'll tell you a little more at the end about how we're going to change this up even a little bit more to make it even more interactive in the future. So it'll be fun. All right, we'll now begin this evening's session kicking off with cervical cancer, specifically the new data in locally advanced cervical cancer, first line, second line, and how it impacts clinical practice. Leslie, I'm going to turn it over to you to lead the segment. Dr. Randall.
Great. Thank you, Tom. I'm excited to lead this. I think I flew the fastest, and I'm not even going to be here the whole time, but I did want to come and talk about all the hard work that you, our sites, and our patients, and us as a leadership group have done in cervical cancer. And much of this data is GOG data. So we're going to go through locally advanced, frontline, and second line and talk about the developments. So I think the big talk on the street is Keynote A18, and this is a chemoradiation trial with or without pembrolizumab, and comes on the tails of CALA, which was disappointingly and surprisingly a negative trial. But this year at ESMO, Keta LaRusso did present the positive results of the Keynote A18 study, which is very exciting. We clearly know that immunotherapy plays an important role in cervical cancer, and here you can see an improvement in progression-free survival of the hazard ratio of 0.7, and the overall survival not yet mature, and the final overall survival results will be forthcoming, but already somewhat of a trend towards an OS benefit, but certainly no decrement. And here I want to spend a minute on the forest plots, because there's been some discussion about the forest plots. CALA-B negative, A18, the key differences are the risk population, and I want to draw your attention to the FIGO staging at screening. Is 2014 staging, that the improvement in survival PFS may be driven by this higher risk subgroup. So I want to stop there and open this up to the group for some discussion on what you think. Do these subgroups inform the results or the interpretation of the Keynote 18 study?
Rob, go ahead.
Anybody
I love the
can
way you
start.
look at that.
Yeah.
Very
I'm like launched and ready to go here. Yeah.
Let's go.
Well, I think these are really this is a great exercise for a randomized trial to look across a number of parameters that might be informative about the outcomes of the trials, just as you mentioned. And so we know that patients that enroll on trials can't always be controlled for every variable. So we want to know kind of just in general how the performance of the intervention relative to control did in each one of these subgroups. But it's always important to remember that every single patient on trial essentially fits into one of these cohorts. They have an age, they have a race, they have ECOG performance, they got a certain type of radiation, they have a certain stage. So every single one patient actually is in every single one of these graphics. So the hazard ratios you see on the right-hand side is one way to represent this data. My personal preference is to actually look at their interaction, because that tells me whether or not there is something that we should maybe pursue as a hypothesis to kind of study in a line going forward.
If I can just add on, so I actually thought you were driving at the stage difference between CALA and A18, and maybe why that was the difference in results. And I am certainly very intrigued by that. I know, Brad, you gave an awesome distillation of this. I thought it was really fantastic and honed in on some of these key points. And you have a great slide that I think you're going to be showing us pretty soon about those key differentiators between those two trials.
Just go there right now.
Perfect.
Right. Well, that was a softball. King.
So Brad, why was CALA a negative trial?
So I'm not sure. I wish I was that smart. There were plenty of events in CALA to show a difference, okay? And there was no difference. We weren't even halfway there, okay? you could say, well, it was the risk of the patients. That's only relevant if the sort of more systemic patients with systemic disease, let's say aortic nodes, that the immune cells were not destroyed by the radiation. Well, but all active tumor, including aortic node metastases, were radiated. Again, I don't know. These are different molecules, PD-L1 versus PD-1. You'll tell us probably, Leslie, and compare is not the right word, but discuss BCC, which is atezo PD-L1, and ultimately 826, which is a PD-1. My hypothesis is that these are different agents, and different agents have different results. I don't know, what do you think, Bhavna?
Yeah, but I think, that comparison isn't necessarily fair because BCC also included bevacizumab, and, is the bevacizumab adding to the PD-L1? And to say that, it's just the PD-L1, I'm not convinced of that.
So Leslie will show us, I think, because I know Leslie pretty well. She'll show us the 826 Bev cohort, which is just what you said. And if you take 826 Bev and compare it to BCC, it's still a little better. But the control arms are the same.
It's comparable.
Comparable.
You can't say it's better.
It's not the same.
Right.
You got me. Okay.
Great. So I think it's these differences are important. I've done the statistically invalid analysis of looking at the control arms between CALA and Keynote A18, and the Keynote A18 control arm performs a little less well than the control arm of CALA. So there was more room to show a difference
I don't think
in
that's
A18
trivial.
versus
I
CALA.
don't think that's trivial at all. I think that's actually, when I look at a randomized trial, the first thing I always do is look at the performance of the control arm and
Exactly.
see if it meets the criteria, the estimates that we thought initially. I think that's an absolutely great way to look at these trials because it may inform that maybe this is a different risk population. And you're right, maybe there is more opportunity to show a difference.
I think it's right there in your top eligibility line.
Yeah.
Exactly. If it's a little higher risk population in 18, so without an additional intervention, you expect the control arm to do a little bit worse than CALA.
Can you go back
Brad's
to the
shaking his head.
difference in A18? I just want to,
This is it right here.
no, go back to the
Oh, the-
differences between the arms.
Here you go.
So I'm going to ask, just because I love all of you and I love all the audience, but that doesn't mean I can't ask you hard questions before I'm looking at you.
We're here. We're here for it.
So if I look at this, okay, there's a 10% delta, which means 57% at 2 years didn't need it. They didn't need it.
Well, they need something
Well, the
because
fif-
I don't want the
at 50
100 minus 57% of my patients to not be cured. This is curative intent therapy.
57% didn't need it because they were cured without it at 2 years. So, and there's no overall survival advantage. You show that on the right. So unlike PARP inhibitors where, I got to treat them in the beginning, and there's a big delta, not a little delta. This is what people hammer me on, so I'm not trying to hammer you. But I got a 12-month improvement in overall survival in 826. 12 months. I got nothing here yet.
Right.
So can you justify using A18 pembrolizumab chemotherapy and radiation, particularly in 57% of the patients that don't need it at 2 years, for 10% delta when I got in my pocket a year of survival, many of whom are probably cured in the 826 setting? Can you justify it here?
Yes.
I think so, but I think
Absolutely
it's a
can.
little nuanced though, and I think Leslie, when she showed the data about the different stratifications, the subgroup, not to do any, not to take anything away, but maybe we need to be more strategic about the stage of patients that we enroll in these trials. Do those stage 1Bs. Yeah, and this is 2014 staging, so it's a little more nuanced than that. But do those 1Bs really benefit from this, or this? I know there's probably no such thing as a low-risk cervix cancer patient who needs radiation, but there may be some nuances between who we're putting on these studies, and I think we need to be smarter about that when we're enrolling. I do also want to state both CALA and Keynote 18 were able to enroll in a timely fashion and administer really excellent radiation.
Across
That
the
is
world.
Across
During
the world.
COVID.
During
which
COVID.
which is a testament to being able to do these trials and do them well.
So Rob, you said, of course we can.
Yeah, here, go back, because I think people get this kind of confused also. So when you looked at that 57 versus the 67.8, what you're looking at is the the proportion of the the number of events over the number of at risk. So, and there's a lot of censoring. So we know that these are kind of unstable, and there's probably more censoring on the experimental arm than not. We don't really know that because we don't see it here on the graphic, but you can see the number of dots, the little vertical bars. So what's going to happen at that point in time is over time, those will split even more at the tails as they become more mature. But it's not 10% difference, because that's an absolute.
I was baiting you, and you got me.
It's 10% of the 57, so it's actually a 20% increase in the relative risk, which is the hazard ratio, which is right there at 0.7.
That's
So this is a 30% protection against progression or death if they got treatment. And not knowing what's making the difference between the 57% and the 68% is why we still need to do work.
So I was hoping that you would say that, though, because I think we can, and we need to do better, and all of us are working on it every day. But I don't think you can look at it as a 10% delta, even though I tried to bait you, and as usual, I didn't. But I do think that there are some serious immune-related adverse events that occur here. But you have to be alive to have a complication. That's a Phil Desire sort of ism. But anyway, keep going, Leslie. This has been filed to the FDA. This has an action date of January 20th. I predict that it's done before the winter holidays, which is 3 or 4 weeks away.
Yeah.
I'm not sure I'm right. I think the issue will be what the indication statement is, whether people overinterpret the stage differentiation, Angeles, that you brought up, whether even, I don't know, but maybe the regulators are going to get, people might get confused on the staging, and they might think that the staging in this trial is the staging that you use today. So anyway, go ahead, Leslie.
Yeah, I mean, I think in the right candidate, this is going to become the new standard of care, and we'll await that approval. But I do also think that there's still room for improvement. So hold that thought, and let's move on to interlace. So hold your thought of the control arm performance is relevant, and let's talk about interlace, because I know everyone's really excited about interlace and induction strategy, which I think is very smart, and a therapy that you have on your shelf and you can start giving to your patients tomorrow, and maybe some of you have already started giving them to them today. So induction chemo with carboplatin, AUC2, paclitaxel, 80 milligram per meter square for 6 weeks prior to initiating chemo-RT. And this trial showed both the PFS and an overall survival advantage. This study has the advantage of having a very long-term follow-up because it went on for 10 years plus. So here we have this difference. Are you all incorporating this into your practice?
Consider it.
Yeah, Brian?
Thanks, Liz. I think, I think while there's limitations to the study, I think it's a game-changing trial. And to the point Brad said, waiting for FDA deadlines on other trials and we need regulatory approval. To your comment, we could start this in our practice.
Yeah.
I've already given this to patients. It's important to discuss the side effect profile. It's a little bit different. There's alopecia or hair loss, so here, and but the other, from a practical perspective, depending on your institution, sometimes it takes time for a patient to get into the radiation system, to see the radiation oncologist, to get financial approval, and patients also want to get treated. Again, you could start treating the next day or as soon as you get them the CTU, and I don't think it does any harm. We could all question, I'm sure, from a statistical point, is how much benefit is there, but it's definitely not causing harm, which is our first goal.
Does it make any sense to add pembro to this?
I'm not sure about that, but what I would do is I would use interlace and then I would use A18.
Yeah.
So no, I'm sorry, pembro at the beginning. No, I'm not sure if you should be done with induction chemo, but it's not a one or the other. In my view, it's both.
So the more is more theory.
More is better.
Right.
And these are young patients, right, Tom?
Absolutely. Your only chance for cure is up front. I mean, really. I mean, there are some exceptions, but not many. The other thing, though, that on the other hand, is that this is a regimen that you can easily administer in a resource-challenged area, which is important also.
Right.
No
Remember
question.
where the greatest amount of disease is in the world. It's in resource-challenged areas, so it's really important.
Right. I mean, many of us just attended the IGCS meeting in Korea, and I was astounded to just find out a lot of these places don't have access even to radiation, things that we take for granted,
Brachytherapy,
much less
especially.
ever having access to immunotherapy, and some are even challenged to get access to chemotherapy drugs such as the ones used here. So I think trials like this are incredibly important, and not just doing treatment trials for patients who have the disease, but really focusing more on prevention as well.
So just some closing comments on interlace. This was a lower risk population than A18 or CALA, more stage 2, and so if you do look at that control arm, what you'll find is that it does underperform what Outback or some of our other trials in the stage 2 120 population did. So that's, I think, of interest for this trial as well. So I personally, I would like to see the publication and just
Yeah,
get
that's
more
what we-
information.
Agreed. I think that's the kind of the key missing piece there.
And then just a plug for our upcoming trial in this space. We're looking at a PD-1 CTLA-4 bispecific antibody combination, and so we're hoping that this will build upon the success that we've seen with pembrolizumab and immunotherapy in the chemoradiation space, and hopefully cure more patients because, Tom, as you said, this is the curative intent space, and this is our opportunity. Great. Well, I'm going to turn this over to Dr. Solani to talk about recurrent metastatic.
All right, thanks. That's a great overview, and hopefully create a little bit more clarity in the first line, but also some more confusion. So I'm going to start with Keynote 826, which has been around since 2021, and so we should all be familiar with kind of this and how it's changed practice. And just as a quick reminder, this was the incorporation of pembrolizumab into frontline chemotherapy with platinum-based agent paclitaxel with or without bevacizumab. And then just to kind of highlight the results here, we saw a significant advantage with PFS and overall survival in what they define as a PD-L1 positive or CPS greater than or equal to 1 population. Now, just a reminder, this was a majority of the patients. This was about 90% of the population that had PD-L1 expression or CPS greater than 1, so a majority of the patients. And we saw this profound benefit that we started implementing into practice soon thereafter and got FDA approval a couple months later. So very, very fast into practice. And then just recently at ESMO this year, this was a virtual presentation, we heard about BEAT-CC. And the BEAT-CC kind of is similar to Keynote 826 with two kind of main exceptions. One is it's using atezolizumab, which is a PD-L1 inhibitor as opposed to a PD-1 inhibitor, and bevacizumab was required for these patients. Now, this study has not yet reported PD-L1 status, so we don't know the percentage of patients or if there's any difference in outcome, but the result was comparable. You can see a benefit in PFS with a hazard ratio of 0.62 with the incorporation of atezolizumab, and then in overall survival, you can see here, once again, a benefit with a hazard ratio of 0.68. So really kind of reaffirming the role of checkpoint inhibitors in advanced or recurrent cervical cancer as frontline therapy. Now, this is kind of alluded to earlier, and this is the overall survival by bevacizumab use. And what this is looking is at the Keynote 826, where bevacizumab was optional or just kind of investigator choice. Now, about 60%, a little bit over 60% of patients did receive bevacizumab. So this is just kind of a little, subgroup analysis here. But you can see the patients who received bevacizumab did have an improved outcome in, I don't want to say compared to, but when you look at those in difference to those without bevacizumab. So really comparable to what we saw with the BEAT-CC. And I just want to highlight here that I think the takeaway from this is bevacizumab is an active agent in cervical cancer. And here is a really nice slide that Leslie created here, and you can just kind of see the difference. And I always like to highlight, 1985, some of us were still young, some of us were like already in practice here. But you can see that the survival here was seven months. This is overall survival at that time.
I mean, I remember this.
Right? I remember when we first started, right? We would talk about how this was, not a disease that actually chemotherapy was sensitive to chemotherapy. And then you can see with the incorporation of bevacizumab, we started finally making some gains, and then with the addition of pembrolizumab and now atezolizumab. But I just want to re-highlight that the bevacizumab and checkpoint inhibitors are both active agents that have changed the landscape for cervical cancer.
Can I jump in? I love this because I think we started to take Bev for granted when Keynote 826 was presented and published, because I think there was this. We don't like to give Bev, and you'll get into the toxicity and remind us how low the fistula rate is, but we don't want to give it. We thought, oh, Pembro makes up for the Bev. We don't need to give Bev. But Beat CC really hit home. I thought, wow, Atezo's better than Pembro. That doesn't make any sense. And then if you pull out that Bev cohort of 826, then you see it's actually Bev.
Yeah.
Yeah. So I think that it's just a reminder that these can be used in combination, and there really shouldn't, at least in most practices, that this is really feasible. It's a lot of chair time, but these are patients who are able to get this, and I'm going to show you in a
Can
second.
I just be devil's advocate for a second? Can you go back a slide? Go back one more? So when you're comparing this OS by Bev, the with Bev group, and then the without Bev group, how are they similar in terms of their clinical demographics and in terms of the disease?
There you go.
They're very different.
They're very different. Look at look at them.
And so that's what I'm saying. So I think I'd be very,
control arms are
to
Right.
to personally disclose my practice, I utilize bevacizumab with pembrolizumab when it's clinically appropriate. There's
And
certain
your good
patients,
prognostic patients.
right? And there's certain patients you're not going to utilize the drug in because there's
I love that you're
contraindications.
bringing this up.
So I think it's really important before we jump to make that conclusion that I would go back and I would analyze this data if it's available to really see what's going on.
I think that's a great point. Leslie, we're going to...
right. And look, you can see the control arms are different.
But the same as in Beat CC. The patients that went into Beat CC are not the same sorts of patients that went into 826.
They're better because they weren't eligible for Beat CC unless they were excellent
Exactly.
Bev candidates.
So if you
Right.
can,
So
Right,
it's
right.
Rob's
Right.
point,
corollary to the argument.
Right.
if
Yeah.
you
Right, which is
control
why you're seeing.
That's right. These Bev patients.
the control arms of
Yeah.
826 with Bev, without Pembro, are very similar to the control arm of Beat CC without Atezo. So it suggests that the two populations in the 826 Bev and Beat CC are similar.
Right, with Bev.
But we also don't know
With
what...
Bev.
With
With
Bev.
Bev.
But we also don't know why patients didn't get Bev.
That's right.
Yeah,
Right.
we actually
It's-
do.
I haven't seen that reported.
So in the ESGO Keto-LaRusso, it stated very clearly why patients didn't get Bev in 826, and it was rarely because it wasn't available. It
Well,
was,
I know the study provided it if they wanted it, but I cannot think of 30% of my patients who are not Bev eligible.
well, again, I don't want to get into the weeds here, but there were medical contraindications, as you might imagine, uncontrolled hypertension, and importantly, and kidney disease, because that happens.
Sure.
But importantly, active tumor in the pelvis, which is a worse prognosis group.
Radiated
that
field, rectovaginal nodularity,
all of that might get a
MRI
fistula.
involvement
Those are the hard call
Yeah.
ones. Then there's the soft
Yeah.
call because you
Yeah.
have bias.
Right.
Right.
I agree with
the
that.
gray
Right, yeah.
areas.
bias.
Right.
Right.
There's no question.
But to the point that in with the use of bevacizumab, you can see here that the rate of fistula, which I think is probably all of our worst outcome with bevacizumab, we see very low rates. So this was very tolerable in this population. And so I think this is an important takeaway that we should be able to use it. Yes, it does occur, but it is a low rate. And here you can see that the other events that we see, just to the point of medical comorbidities, hypertension is really common. We do see embolism rates and then proteinuria as well. But perforation and fistulas do occur, but at lower rates.
So if I could just jump in. So the fistula rate in 240 was 11%.
But that's grade 2, 3, and 4.
Exactly.
Right.
And if you didn't have a colostomy, it's grade 2. So to say that it's, because this is grade 3, which means you got a colostomy or
Right.
whatever. And so once you put the grade 2s in, it's 11%. And we didn't understand why they were happening, to your point, Angeles. And every fistula in 240 had been radiated, and many of them had tumor in the pelvis. So I think we figured that out, and that's why in 826, about 35% were deemed by the investigator to not be good candidates for Bev.
And I think we need to continue to do that, but at the same time not get too conservative not giving Bev because the benefit is clearly
It's
there.
what Angela said.
Is
If
the
I could-
benefit clearly there, though?
Yeah,
Yeah,
that's right.
right.
Is it?
Yeah.
You can give
I'm
it,
not sure
right.
it is.
If you can give it,
The
you
event
should,
rate in
right?
those two, the event rate's about the same, as you see.
Bev raises everyone.
Or
there was
or
selection
the
bias.
patients who
There's
got
selection
Bev
bias.
There was
Were
selection
elevated.
bias.
There's selection bias.
There's a
Right,
little-
there.
Right,
That's
selection
I
right.
don't think you can definitively say that. I really don't. but that's just me.
Yeah, when it's investigator choice, it makes it difficult. When they're
does.
excluded,
Right.
it makes it difficult, right?
Yeah.
Correct.
Right.
That's fair.
All valid points. So
So before we move on to second
Yeah.
line, I just want to poll the group. Like, what do we think, where do we think that immunotherapy has the best role? Is it in the locally advanced space, or is it after patients progress and in this and first line recurrent space?
yeah, and that's exactly where the confusion comes in. Is now
That's
that we
what we're
have
talking
we have this great data in 826, now beat CC, but now we have this compelling data in A18. So how does that shift our practice?
Well, I think A18 is just so early still. 2 years out from initial diagnosis is still pretty early. I'm looking forward to seeing the long-term data. But what I find so amazing, and it is so awesome to be practicing G1
Yeah.
oncology right now,
Yeah,
right?
yeah.
Because we're seeing this play out in clinic right now in front of us, where
Yeah.
people are alive and without evidence of disease who present with stage 4 cervical cancer,
Years.
really
We've-
sick in the hospital. Never would have seen that
It was
before.
never in our dialogue. That's how
And
it's
from
changing.
826, it got better.
Yeah.
So I would
yeah.
expect A18, based on the biology and the mechanism of action, to get better.
I do too, and I always think that the earlier our opportunity to get in front of a tumor biology, the better. So I always want to go as early as possible. I think our work cut out for us is to understand how to do the prior exposed patients.
Yeah,
And
for
how
sure.
do we deal with those?
Or can you treat and retreat with
Exactly.
immune checkpoint? And we'll see
Yep.
some of that presented tonight in the endometrial space, but we just don't have that yet for the
That's right.
cervical space. But we will. That will be coming slower than in endometrial, but it will be coming.
And even in the front line, can we do better with the bispecific study
Right.
that you're leading? So I think there's more
Combinations.
work.
Yeah.
Exactly. Yeah, I think the combination IOs are very underdeveloped in cervix and have a lot of potential. Wonderful. Great discussion. I'm going to pass this on to Dr. Slomovitz.
Yeah, no, thank you very much, Leslie. And it's interesting when we're start talking about the second line, it's changing. The reason why it's really changing is because of all the great work that's being done in the newly diagnosed patients, locally advanced, and in the first line, because prior to that data coming out, second line therapy was easy, give immunotherapy. But as you move down to the first line, an unmet need here is what are we going to do in the second line, what are we going to do in the third line, and we need to come up with better treatment options. Here's the NCCN guidelines sort of highlighting what some of those options are, and as mentioned, in the second line therapy, pembrolizumab's there. Well, until we have IO after IO data, cross that off the list because we're moving it forward. Cemiplimab is there really for patients who are PD-L1 negative as an option. But here we have tisotumab vedotin, which I want to talk about. I know you're going to touch base on some of the HER2 data that's out there. Here's a study. Here's the Innovative 301 that we presented recently. Ignace Vergote presented it as the ESMO conference. It is a randomized phase 3 trial looking at second or third line patients. Again, we talked about maybe it'll go in the second line of an ADC, tisotumab vedotin. It's an ADC against tissue factor versus investigator choice chemotherapy. No, not a lot of great options. Options are always good, but when you have 5 options, it means none of them are really great. In the second line, third line setting for recurrent cervical cancer. Now, this is in the U.S. This was a confirmatorial trial based on the 204 trial, which Rob Coleman led, getting us an accelerated approval in the setting with a 24% response rate. But as always, with an accelerated approval, we need to do a confirmatory trial, which we have done here. Tisotumab vedotin versus IC chemotherapy, similar baseline characteristics between the 2 arms. I'm highlighting here prior anti-PD-L1 therapy. Really one of the first trials allowing for checkpoint inhibition prior, similar between the 2 groups. And here are the results. Here are the results that we want to highlight. The primary endpoint here was overall survival. A hazard ratio of 0.7, representing a 30% decrease in deaths in those patients taking tisotumab vedotin, I'll call it TV from now on, versus investigator choice chemotherapy. And you can see here at 12 months, the difference is really 48.7% of the patients still alive with TV versus 35.3% of the patients. Exciting data, a positive randomized phase 3 trial in this setting. And I'm interested here to hear from the group. Rob, I'll pick on you first. You led to the accelerated approval in this setting. Now in our GOG NGOT collaboration, we had confirmatory data. But What are your thoughts? Specifically, we saw a decrease in response rate from 24% to 17% here in the TV arm, but share some of your thoughts on this agent and how it'll change practice.
Well, I mean, I think it just confirms what we saw before. The patient populations are a little different, as you know, but to see this, hit all of its objectives, hit it for PFS, OS, objective response, it was remarkable. And I think, as we've been kind of the theme of today is to look at what happened in the control arm. The objective response rate in the control arm was 5%. I mean, it just goes to show. You said like we had 5 options, none of them are good. Well, now in the current environment, you can really see how poor and how much the need is. So this is a tripling of that expectation of response rate. That should not be minimized.
And that was exactly the same control arm performance in Empower,
Yeah,
cemiplimab.
right, exactly.
So that is the current, and we thought it was like double that before we had IO in the front line and Bev in the front line, and it's just a different time where you do gain a lot in the front line by using those agents, but it appears that later on, and I don't know if they're related, it could be coincidence, but the response rates are much less than what we used to see.
I think
Well,
also,
part of it's a phase 3 versus phase 2 data. Right?
You
I mean,
always
we saw the same
open
thing. You
label.
see the same thing in ovary as
true.
well.
Right.
I was gonna say, I think it's
Great
also
point.
nice that about a quarter of patients had prior IO, and this is going to like kind of, it's our practice today. So I think it's representative of what we're seeing.
We
and
didn't
I
have that at all.
congratulate the investigators because I think this is a really game-changing study.
Definitely.
No, it's interesting. And to Rob's point, we did see secondary endpoint PFS was a 33% or a hazard ratio of 0.67, which was nice. It's important here. Sometimes we look at the median overall survival differences. It's 2 months, but sort of the whole picture, looking at the whole story, we're doing better in the locally advanced patients. Get some time there. We're doing better in the first-line metastatic patients. Looking over the course of a disease, where each step, each significant study that we have is overall going to make a difference for our patients, and that's what we want to do.
Yeah,
it's just not at one line of therapy; it's at all lines of therapy.
Yeah, I really don't like using medians to describe the impact of therapy here. I think it really undermines what we've shown here. Remember, when you start at the very beginning, the left hand of that curve, and you're looking for overall survival, you don't know what's going to happen in 6 months. You have no idea. All you can do is say, I'm going to treat you, and we know that the hazard ratio is representing what that risk reduction is at every single time point. Right. You might make it out to the median, you might not. Right. But all you can do is promise that, based on what we saw in the study, that there was going to be a 30% reduction in the probability or the risk, the hazard, that you're going to experience one of these events. That's the key.
Yeah, I just want to touch on something that's very different than what you're talking about, but was my clinical experience with this drug. And I like what you said about incremental gain. One of the things I've noticed is patients who respond is the duration of the response. And I've been really surprised because sometimes, with the ocular toxicity, I've had one patient or more than one that had experience with that and had to hold the drug. She had this really long, prolonged response, and that's huge. Where before the other drugs had such low response rates, or if they did respond, it was fleeting duration of 2 to 3 months. Now we're seeing clinically duration of response that's, I would say,
multiple
in the 8-month
cycles.
period.
Yep.
So we sort of compare the phase 2 to the phase 3, but we also compare phase 3 to real-world evidence.
Exactly.
And I've had better response in the real world because there are patients that don't have measurable disease.
Yeah.
I can see it in their lymph nodes, FDG avid, that don't fit the 1.5 short axis. And I put that patient on, and she does great because she's a better prognostic group.
Good point.
And so I'm actually, I really think that although the phase 2 expectedly had a different population, real world evidence, just what you said, Angeles, also it's a different population.
Yeah, that's great. One of the things I want to highlight here, and Angeles mentioned it, is the side effect profile. In particular, the ocular side effects. I had the fortune of being involved with some of the first in human studies here, and we didn't know what to do with the ocular side effects.
Exactly.
Yeah.
Now we've matured that into a really aggressive and I would say successful ocular mitigation strategy, which has really, in our experiences, helped to limit the side effects, the ocular side effects seen, and this includes using saline drops, corticosteroid drops for our patients, not allowing contact lenses, using cold packs. Bob, I know you've given a lot of this in your practice. How have you seen the ocular mitigation strategy really change over the years? are you still seeing it that deserves a black box warning, or is it something that you think will change over time?
We're all listening.
Yeah.
It's being recorded too.
Yeah, no, I think you're absolutely right. I think with the mitigation strategies, patients are really tolerating these therapies well, and honestly, often, you know, I send the patients to the ophthalmologist every cycle like you're supposed to, but you know, some of them miss their appointments because they're like, I'm fine, I don't need to go. So, you know, and while I try, I think, you know, I think it's hard when patients are doing well on it and they're on it for a long time, as Angeles and Brad said, to go every cycle, as is required by the label.
But in this trial, they were not seen every cycle. They were seen at baseline.
Correct.
Right.
Because it's a surface abnormality, which is redness, conjunctivitis, cornea keratitis. In other words,
No,
if you
it's
don't
a-
have blurred vision or a red eye, in this trial, you didn't have to go to see the eye doctor. So I'm hoping, Brian, are they going to sort of
Change that?
change that? You asked her a tough question. Come right.
All right, so let me move on. I mean, we can't predict, but to your point, there's only 5%. Only 5% of the patients had to discontinue for
Right.
ocular side effects. And let's look at the other one, peripheral neuropathy. Again, it was only 5% that needed to come
Right.
off.
Yeah.
You know, one of the things that Brad, you and I have discussed, there is a rate of peripheral neuropathy, but people worry about the cumulative now with they're getting previous taxane. It's not the same.
No,
It's
a
not the
different
same. So what have you? What are some of the things that you've seen?
So there are dose reductions. There's 3 doses, 2 lower doses, and dose delays, which has been effective in other taxane and other neuropathies. So I think it is cumulative. I think also fatigue is there. As I understand this, dose intensity does matter. I think, as you remember, we've studied weekly, and I don't know if we ever have really talked about the results, and maybe we don't even know. But it's probably the peak that matters rather than the repeated administration, rather than the AUC. I'm speaking out of sort of my opinion. So I think dose intensity matters, but I also think quality of life matters. So
Yeah.
there's a sweet spot there.
I think it does too. And I mean, for me, the neuropathy has been more of an issue by far than the ocular toxicity
Yeah.
for this agent. And it has a motor component too. So that fatigue, it's a weakness, not much as a sensory or a pain as we're accustomed to with the taxane. And to your point before, Angeles, you can, I mean, in my experience, speaking only from my experience, you can hold this drug, allow them to recover,
Yes.
and they'll stay in that response.
Yes,
And
exactly.
It makes no
That's the same
sense.
experience I had.
Yeah, they'll stay. My patients have stayed in that response and then been able to go back on drugs.
Yeah, exactly.
And I think the neuropathy is a real issue because unlike your ocular and your bleeding events, most of those, you know, will recover and within a short, you know, within a month and a half. But only about 30% of the neuropathy actually recovers. So, you know, it is a real issue in terms of quality of life.
Yeah. And the last thing I want to talk about when we're on TV is, Leslie, I know you're doing some great work on looking at TV combinations. Do you want to describe some of the work you've been doing and where do you think this is going to lead to?
Yeah, part of the team. So, well, Brad presented the TV Carbo, TV Bev, TV Pembro toxicity data. What was that now, like 2021? And basically you can put them together at their standard doses as single agents. So that's good. You don't have to reduce the dose of either. And then to use them, you could use, we've looked at TV Carbo, TV Pembro in the front line and seeing response rates around a 50-55%. I mean, you look at 826, like you've got 65% response rate. So sort of comparable, maybe a little less, but where it's really interesting is in the second line at 38% response rate, TV combined with Pembro, which is about additive for the 24 and the 14 that you saw. But in my experience, the DOR is longer. So you may get the same number of patients into a response, but the DOR, and that's not backed up by data, that's just backed up by my experience. Now, those, you know, that I was giving a lot of TV Pembro before Pembro was really available frontline, and so now my patients are kind of caught up, so to speak, on Pembro. I'm not, but I'm actually still using it. And I would tell this audience not to use IO after IO because we don't know if it works, but then I do it, so I don't know.
Yeah.
I don't know if that's fair or not. I just want my patients to keep going. So.
Can I make a quick comment before we move off? I think the other thing about quality of life and toxicity is that I think Leslie, Brian, we had talked about a lot of patients with cervix cancer don't usually get another therapy after second line.
Yeah.
And having a therapy that is effective, doesn't debilitate the patients, is really important, because as this landscape continues to shift, we may have better other options in the future that these patients can continue to go on.
And we're going to get, one thing I did want to just briefly mention, it ties into that, is that when we treat patients, for endpoints on clinical trials differently than we do in the real world. So we tend, obviously we talked about duration of response, we talked about response rates, but we treat until progression in the clinic. So stable disease is an important, a positive, important endpoint for a lot of trials, for a lot of our patients, and the lack of progression in those stable disease patients is also meaningful.
I
That's a
wouldn't
big
bet
proportion.
when you don't have another therapy, I even treat through
Yeah.
slow progression.
Until you have confirmed
Until you have a
progression.
right.
I have to say, I don't always do that. I actually see what the patient's thinking, what's on their bucket list, where
Right,
they're going to
of
go on
course.
vacation.
Yeah.
And
That's fine.
Yeah,
No,
so I
no.
kind of have a little bit different approach. It's personalized.
Yeah.
Remember,
Yeah, I
so,
think we
Rob,
all-
to your point, I
we
think
all do that,
options
yeah.
are great. It's so exciting how many options we
Yeah,
have.
exactly.
Just to keep us on time, Leslie, do you want to go back to you? Talk
Sure.
about some more
So
great options
we've
in
been
cervix.
excited about a HER2 option in cervix since we did TCGA and saw the HER2 expression, and hadn't really thought a lot about HER2 expression in cervical cancer. It's more common in the adenocarcinomas than in the squamous cells. But we had a neratinib trial with sort of modest response rate. Brad, you were one of the investigators. It was in the 20s, the response rate for neratinib, HER2
But those were
positives.
HER2 mutations.
Those are different.
Yeah,
Isn't that
Those
right?
are
Yeah.
mutations. And so the opportunity here is, if it's not expressed, the antibody's probably not going to work. But if it's mutated, the TKI might. So it's pretty, we have lots of, so it's not,
Two different options,
Yes.
two different strategies, two different approaches. So the approach with trastuzumab deruxtecan is an antibody drug conjugate that just binds to the HER2. So it's just using the HER2 to get into the cell, so to speak. And the cervical cohort of Destiny Pan-Tumor showed a very, very surprising response rate in the IHC 3+ of 75% and 2+ of 40%. With the median DOR of over a year of 14.2 months and the upper confidence interval not reached. So this was very exciting data. This is that was presented initially at ASCO. This was an update at ESMO that included the progression-free survival of these patient cohorts. And my hash marks got a little wonky, but if the orange line is the IHC 3+, and the blue line is the IHC 2+, and the green line is kind of the difference of the two. So it appears that there's a differential effect by the intensity of the expression, but these are still small numbers, and I think that we just really need more data here to get a better idea. And then, interestingly, in pan-tumor, we had been scoring cervical cancers by the breast criteria, but in Destiny Pan-Tumor, they scored it by the gastric criteria. So the question is this a better scoring system, and is this the reason that we saw this unexpected response rate in these, or is this just a better drug? And I think in the trastuzumab deruxtecan has shown to be a highly effective anti-HER2 therapy in multiple settings, not just in cervical cancer, so it may be partly the drug as well.
Yeah, so exciting, and it's on NCCN guidelines
Yep.
already. So
Yeah.
I've been
Use
using
it
in
right now. I've
practice.
used it twice already.
Yeah.
And we don't really know what percentage is expressed because we haven't been testing it.
Right.
It's probably more common in adenocarcinomas, but I think this is something we should probably be testing across the board, looking for options for the future.
Awesome. So we're almost out of time, so I'm just going to hop over and take this opportunity, selfish opportunity, to encourage folks to continue to accrue to the ROCK trial. Accrual is going well. We're up to 105 patients randomized in the United States. We're adding on sites in Brazil and South Korea, and expect those to have a high rate of accrual in those countries, but definitely really want to get our investigators. You've all worked so hard to get this trial open, get yourselves credentialed to do the surgery. So let's keep going with ROCK, and with that, I'm going to hand it over to the ovary team. Thank you.
Keep rocking on the
Right.
rock.
Rocking on.
Congratulations on the surgical trial.
Yeah.
Yeah. Good job.
Great work.
Yeah.
I was going to say, you know, once Brazil and Korea activate, I think it's going to take off
Yeah.
quickly.
Inflection point.
Yep.
I'm waiting. I'm
Elbow.
Great
excited.
job.
Elbow.
Elbow, that's right.
So Rob and I get to talk about the evolution of ovarian cancer. And we were tasked to discuss biomarkers as well as therapies, novel therapies in this area, and the GOG trials. So here we go. So a little bit about biomarkers, one of my favorite things. Biomarkers can come from a variety of different places: blood, tumor, ascites, and that's even a limited list. There's even other options for acquisition of biomarkers. In terms of the ovarian cancer space, the opportunities here are for detection and diagnostic purposes. We've been working in this area for a long time with some disappointing results, but I think we need to keep trying to identify patients who have this disease, and especially try to identify them early in their course and hopefully improve survival. Prognostic biomarkers, we're aware of several prognostic biomarkers, including BRCA1 and 2 mutations, HRD. CA125 is actually a prognostic biomarker as well. Predictive biomarkers, many of those on the list, and then therapeutic biomarkers, which I really want to take that time to focus on the lower half of that list there. So therapeutic biomarkers, CA125, you know, we're targeting that with origovimab. We target BRCA1 and 2 and HRD with PARP inhibitors, VEGF with bevacizumab. And then we also have ARID1A targeting therapies. At the bottom of the list are several markers that we're using to target with antibody drug conjugates. And FR alpha is really up there at the top of our list. And then we have different markers that are therapeutic in high-grade serous ovarian cancers compared to low-grade serous ovarian cancer. So I listed some in low-grade as well: PTEN, PI3K, AKT pathway, BRAF, KRAS, NRAS, ER, estrogen receptor, one of the oldest biomarkers ever, and people still don't know how to measure it. And ERBB2 is another one. So we have a lot, and ERBB2 is essentially HER2. So a lot of different options here. So this is a very simplified summary table of the ADCs that are currently undergoing evaluation in ovarian cancer and some of the trials that are being conducted. Obviously, to go through a full complement of all the different ADCs in development would take at least several hours. So we're going to focus on mirvetuximab, the luveltamab drugs, and that target FR receptor alpha. There's also the MIRAB 202. We have SASI here. We have several ADCs that target HER2, some we already talked about, like TDXD. And then the other really exciting deruxtecan drug is RDXD, which targets CDH6. We heard really fantastic results from both TDXD and RDXD recently, with response rates over 40% in patients who have platinum-resistant ovarian cancer, which is out of this world because that response rate is really about 5%.
Yeah,
right? Maybe up to 15 if we're lucky. And then some of the other drugs listed there. So a lot of opportunities. I'm going to turn this over now for Rob for this next slide.
Maybe before we go there, Angeles, you know that I love this slide. I'm going to go back to it. This slide here. You know, we every one of these things. So you mentioned like detection, diagnostic, the prognostic, predictive, and therapeutic components of these biomarkers are really critical. And even though you said we've struggled, right? What's the value of a prognostic biomarker? Like, how do we utilize that going forward?
Okay, well, I'm a biomarker nerd.
I know.
So anyway.
That's why I'm asking you. This is one of these like little softballs.
I use this for my patients too, because they're going to ask, well, what's my prognosis? Ovarian cancer prognosis is really challenging because you have some patients that do incredibly well and some that do incredibly poorly, and under the microscope it looks like the same disease. So I actually really find that it's helpful if they have a BRCA1 or 2 alteration or HRD to utilize that in terms of helping them understand their prognosis, and then link that into why it's important to get this information not just for cascade testing and their other cancer screening, but also to target it with therapies.
Right. So how does that different than a predictive biomarker? Because people always talk about this, right?
Yes, they do. So predictive biomarkers, predictive, and the way that I utilize it is that biomarker predictive for efficacy of a certain drug?
Right.
And a biomarker may be prognostic. We actually had this conversation earlier. in terms of survival outcomes, but it doesn't necessarily mean that it is predictive for therapy. And so in order to really assess if a biomarker is predictive, you really need a randomized clinical trial design,
Yeah.
ideally placebo-controlled.
Yeah, and that's what I was trying to get to, is that we spend so much time trying to understand the natural history of the disease and identify what these prognostic biomarkers are, because we need them to inform our the designs of the trials, that we can actually assess whether or not a particular biomarker can be predictive or not. And that's what it's led to, these types of studies and this kind of portfolio. Because most of this portfolio is looking at the way of incorporating both of those, prognostic factors and predictive factors, into trials that are going forward. So I just put this together to kind of highlight where our portfolio is right now. We talked about in the frontline setting, we have an ongoing trial, the HIPEC trial. Dr. Randall and others are really promoting. This is another one of our global trials. We're excited about to see that go forward in the frontline setting. And in the platinum-sensitive setting, we have an ongoing randomized trial. But you can see in the resistant setting, we have all these trials that are going in, and a couple trials that are ongoing now in the rare subtypes, so low-grade serous, and in the rare kind of histologies that we've seen in the bouquet trial. So what do you guys think of this? What do you think of this?
Opportunity.
Well, I was going to say, yeah, I think
what's
the
the-
front line, the maintenance setting, we talk about BRCA and HRD for maintenance. We have nothing for HRP patients. We have niraparib that's available, but we can do better. And so I think that front line really, and then that platinum sensitive, those are big, opportunity areas. So I think we still always have opportunity in platinum resistant. It's still a devastating disease, but there's a lot of gaps here.
I think there's a regulatory component to this too, right?
What do you mean? What do you mean?
Right. So, you wouldn't choose to only study platinum resistant because there's a low probability of a response regardless of what you do, regardless of if your drug is effective or not. I mean, we see many drugs that are effective in the front line, not effective in the platinum resistant space. But because of how the accelerated approvals are set up, this is the area of unmet medical need. This is where the drug really kind of goes to start off in its development process, but it's also a graveyard at the same time. So it's a little frustrating for me because, I guess I know this, but to see it front loaded in a poor prognostic, high risk space is kind of frustrating for me, to be honest.
I think of it differently. I think of it as having a lot of options for these patients who, otherwise are not going to do well. And, that's why I have about 4 to 5 of these trials open, and I try to sequence them.
Yeah, I do the same exact thing. And I even tell my patients, this is an area of
within
high
the
unmet
platinum
medical.
resistant space.
Yeah,
Yeah,
I have
this is
4
high
to
unmet
5.
need. There's a lot of options. There's not really good off-the-shelf options. So clinical trial, and I believe that. But at the same time, and we've seen some of our trials that we expected to be positive in this space be negative recently, and I wish that we didn't put all of our eggs in the high-risk basket.
Yeah, I like what you're saying, because I think you're right, that we probably are losing, maybe in the earlier settings, platinum-sensitive setting, these drugs may survive and do better because those patients may not be as, beat up from therapies, and the drug may be more active because it's not as resistant.
Traditionally, right, it was
Yeah.
GOG 146 was really our go-to
A
machine under legacy GOG for generating
Q.
an idea of activity in
Right.
patients who were not, their immune system wasn't burnt out as in platinum resistant, and they didn't had a good performance status. I think everything up here is related to approvals. It's why we have a shortage of platinum sensitive, because the time points are near, almost as long, not quite, but almost as long as first line, and you don't get that big commercialization bump. Frontline is really challenging right now because the PARPs have done such a wonderful job,
Hard to
which is
beat.
great. But remember, we have the other, depending on how you want to look at it, many people would still say HRD test negative is an opportunity.
Right.
So I think that all this is reflective of that, and you're spot on in my opinion. Accelerated approval, which you would be challenged to get in those other 2 areas, you can get in
Right, for
platinum
endpoints and such. But Tom, as you mentioned, our strategy in GOG was to do queues of phase 2 trials to identify activity, and then promising agents that would then be moved in. Paclitaxel moved forward, bevacizumab
move
moved
them up,
forward.
right?
You move them forward. So and obviously we're reflecting that history here. We're doing discovery in PROC, and then we're finding our most promising candidates and moving them into earlier lines of therapy. Is that completely necessary, though?
Well,
And I ask this because I also want to hear Angelus's.
and let me just say one thing there. Actually, 146 was more the genesis of, because people started recognizing that PROC was a tough spot.
That's right. So they went.
So they went to the
platinum
PSOC,
instead of- yeah, mhm.
and so that was really the area, and then try to move to frontline.
Oh no,
Mm-hmm.
we're
So the
reinventing.
paradigm's
the wheel.
changed.
Yeah.
I-
Does it
well,
require this paradigm? Do we have to do PROC, then PSOC, then?
No, I don't think so. What I'd like to see is a movement toward more adaptable clinical trial designs, and especially a movement toward designs where you're able to more quickly develop your biomarker. What we're seeing right now really is exciting because the drugs are being developed based on the biomarker, right? Which is very different than what we had before. Biomarkers were always lagging a decade plus behind. But honestly, I think we need to change the way that we do clinical trial design.
I think aerial 4 is probably representative of that, right? You had a PROC group and a PSOC group, and then you had different stratification.
Oh, is it my turn?
Yeah.
Oh, go ahead.
Go ahead,
Make
Bhavana.
one comment, and
Yeah.
especially when we are seeing really active drugs like trastuzumab deruxtecan, you know, in a
Yes.
cohort of 40 patients, like those are things we need to move up into the front line.
And we will.
And we
And if it's
exactly.
not that sponsor, it'll be another one.
Yeah. Right,
Pro
right.
2 and DS.
Right, like when we're DS6000,
all of it. Yep.
right, like when we're seeing
DS6,
significant activity, right.
Yep.
Stay tuned.
Yeah,
All right.
and I think it's also challenging because we still haven't had some of our trials, our large trials like FIRST report out, so
So
soon, right? And I think, right, once we
Phenocombo.
have that, we'll be able
Yeah.
to, you know,
Phenocombo.
right, design trials that
Healing.
healing.
take all of those into account.
So because of the close linkage of the biomarker and the trials, Rob and I are ping-ponging back and forth so we can cover them together. So FR alpha scoring. So let's talk a little bit about this scoring. And I just want to give a shout out to Dr. Katie Moore because she did a great job making sure that the biomarker was right in terms of this drug's development, which gave us mirvetuximab today, which I am thankful every week that I'm in clinic, that I have that drug for my patients.
And let me just pipe in. She's on her way to Singapore right now, or
Yeah.
she was trying to join us. So.
Oh, my
Oh,
God,
yeah.
awesome. All right, be safe. So PS2 plus scoring is a little bit more challenging, but this was really the scoring that led to it's the FDA approved scoring and with the use of mirvetuximab. And this is a little bit more challenging because it's based not just on staining intensity, but also the percentage of the tumor cells staining at 0, 1+, 2+, and 3+. And it's very important to understand that that this is understood by who's ever doing the testing. Right now, we're really lucky. There's several different companies doing the testing. I think everyone's aware of this. But just to make sure that the providers are aware too, that it's for patients whose tumors express greater than or equal to 75% of viable tumor cells that show 2+ and or 3+ staining. So a little bit more complex, but this is what the current approval is based on. 10x scoring, I'm not going to get into too much. That was utilized in older trials, the forward trial. It does not seem to work as well, even though it's simplified scoring. It's not the one that should be used. And I really want to focus on TPS scoring, which is a total percentage of score. And that is a scoring paradigm that's based on the percent of cells with any intensity expression. So the benefit here is it's simple and straightforward. And this is utilized at the cut point here for TPS was greater than 25%, and that was selected for further evaluations in the STRO 002 studies, which I think you're going to talk about next.
Yeah. Well, this is kind of a tee up for the two trials that we're using these two different scoring algorithms. So we have the Reframe trial, which is looking at luveltamab, which is a folate receptor alpha targeted ADC that has demonstrated, very impressive objective response rates overall in the overall population, and in the more selected population, again, very promising level of activity in a population that isn't exactly the same coverage as we see in the mirvetuximab approval. So we have we don't have the direct comparison of the two stainings next to each other, but we do see that the less intense staining was still seen with response rates with luveltamab. So this particular trial, Reframe 01, is actually is working its way through in identifying a dose, an objective response, and then soon, hopefully, we'll clear the bars to go into a full phase 3. So we're really excited to see this move forward based on that TPS scoring. And then, of course, a shout out to Gloriosa, which is open and accruing. We presented that on that previous slide as a maintenance strategy in patients that are getting platinum-based doublets with bevacizumab. And then for those that have the traditional high scoring on the PS2 algorithm, they are then randomized to the addition of mirvetuximab. And so we're really hopeful that this will demonstrate the benefit of a maintenance strategy. We already know that the MIRV-BEV combination is active in patients with measurable tumor. We really believe, I think many of us now believe, that maintenance strategies are essentially taking care of residual disease. So it's really great to have a combination that actually shrinks tumors. And so, again, we're very hopeful for this. So if you have this open, please enroll.
I love this study. I think it's a great study because you can start them on their chemotherapy and their bevacizumab regimen, and then start working on getting the biomarker data that you need.
And you can use commercial testing, which is makes it so much easier now to identify these patients.
You know, I realized one thing I should have mentioned, the percentage of patients with ovarian cancer that have FR alpha expressions. It's over 80% in some studies. There is a range based on histologic subtypes. High-grade serous cancers tend to have the highest expression, but there's also expression in the other ovarian cancer types as well. I know we don't have a lot of time to go into all this, but clear cell, endometrioid, those are other opportunities. I think the lower expression was in mucinous, but it wasn't zero. And then of those individuals that have expression in the high-grade serous group, about 30% actually have the high expression level. So I really love the trial, the Reframe trial, because some of those patients that don't have 75%, they have another option that's an FR targeting agent.
Exactly. And I think if the theme, I think for the audience, you know, the theme that you'll hope to emerge as we go through cervix, ovary, endometrial, is that this biomarker testing, this like next-gen sequencing and immunohistochemistry is incredibly important now more than ever to identify these patients, not only for clinical trial, but also now for treatment options as they continue to expand. So that's going to be the underlying theme. It's so great that we have those options now based on that testing. So it'll be really important for us to continue to work through that.
All right, now let's get to the landmine one. Oh my gosh. All right, you mentioned a little bit about this. I'm just looking at Leslie right now. She talked a little bit about HER2 when she discussed the PanDestiny trial. So in terms of HER2 expression in ovarian cancer, GOG 160 was very informative. Over 800 patients were enrolled in this study, and the HER2 2+ or 3+ IHC expression was only seen in 11.4%. So they screened over 830 patients for that trial. They initially started using one antibody. They felt like they may be underperforming, so they added another antibody. So I actually took some time, looked at the pathology guidelines here, which was even more confusing to me. There's about 5 or 6 different antibodies you can use. There's all these different types of staining here. Breast cancer staining is different than gastric, colorectal, and then for serous cancers, which is important because endometrial cancers, we're used to utilizing the IHC staining from Dr. Amanda Nichols-Fader's wonderful manuscript evaluating trastuzumab in endometrial cancer. So the bottom line is all these different scoring systems are different. Probably the most robust is the gastric type. For PanDestiny trial, they allowed local testing, but it was all centrally reviewed. So I think it's really important to be working with your pathologist if you're going to be doing this test in-house so you understand the type of testing done. So let's move on to this slide. You're going to take it over from here, right?
Okay, yeah. So just kind of a follow-up on that testing. So and what we saw. So you'll see that cervix, endometrial, and ovary will be represented in each one of our presentations today because it was done as a pan-tumor study, and in the GYN space, you can see all of them look really good. So in the ovary overall outcome for enrollment was 45%, and you can see there seems to be some differential on the expression for HER2 based on IHC scoring. And, you know, one thing you mentioned in the 160 trial, you know, back in the day, we were focused on that study was focused on whether or not we could actually do a study with trastuzumab. So we were doing that screening because we had a study called GOG 160 you mentioned, because we wanted to find patients and we could use it. And interestingly, at that time we weren't even looking at amplification. So we were just looking at expression levels, and we found that we were just surprised that there was just so few patients that we thought would be good candidates for that therapy. And so our response rate was very low in that patient population for use of trastuzumab.
But we also were looking for the
2+ that were FISH positive or greater, right? So
Well, no, they actually didn't do FISH in
No,
the
they
study. They
didn't
didn't do
even do
any
it.
amplification. Yeah, they just did IHC. But they were looking for high expressors, as you mentioned, which was a small piece of the pie. And so that 7% or so response rate we saw was just really disappointing. That ended the story. And that was
And well, they
20
had
years
a-
ago.
And they had at that point in time, I think they were still using as their efficacy endpoint response rate rather than
Exactly.
PFS at 6 months, which we switched to later with biologics.
Yep.
There's a whole bunch of stuff to unpack there. They used a different scoring methodology in terms of the 2+ and 3+. That probably led to a less enriched patient population too. So.
But it's just amazing to see this. Like, I mean, we buried that. I mean, I remember saying that, it doesn't have any activity in ovarian cancer. And now we're back here talking about it. Now, because we have ADC now that that's
Yeah.
where we're focused on. So that's just really cool. And, just to kind of see this continue to develop, as you mentioned before, now we're leveraging the expression of these various factors through a number of different investigational agents that are entering the clinic. And it's not just the ADCs. So as you mentioned, the both cellular DNA pathway, cell cycle checkpoints, as well as checkpoints themselves, immunotherapy. You can see many of them are here. We've been studying immunotherapy for quite a while in ovarian cancer. We really haven't hit that sweet spot yet, but it's not like we're not trying, and we have a lot of these trials ongoing right now. So if you have them open, please contribute to them and try to select patients for it. It's just super exciting to see that this portfolio is continuing to expand. So with that being said, there are a few trials that we're looking for your help for. I just listed them here as just some of them. Obviously, any trial that you have open, and I thought Leslie, made a nice comment to Bhavna about having multiple of trials that would affect different potential populations of patients that might be able to hit one of these trials based on their eligibility. So you want to have multiple trials open so you have the opportunity to put those patients on. And this is just to highlight some of them. So we have 3066, which is looking at a WEE1 inhibitor. This trial has recently undergone an amendment. Many of you who have this trial open are working through getting that amendment open. We had a meeting this week. It's working its way through the system. So hopefully you'll have the opportunity to participate on this particular trial. Genelux is looking at an oncolytic virus. This is another strategy that has been evaluated in ovarian cancer as well as many other cancers. This particular trial is very interesting because it's actually using this vaccinia virus to resensitize cells to platinum. And so this trial is open in a few sites. We're hoping to have an acceleration of sites active in the near future, hopefully in the next month or two, so that we can start to enroll on this trial. The preliminary study that led to this adoption of this phase 3 trial actually showed some pretty impressive data. And our hope is that we can recreate it with this regimen with a platinum doublet and Bev. Very exciting opportunity there. We talked a little bit about rare tumors and some opportunities there. Here we have a study for ARID1A expressing tumors, mostly in clear cell and in endometrioid tumors. And this particular targeted drug made by Nuvexis, the GOG 3087, actually is targeting a pathway we haven't really focused a lot of attention to. This is the heat shock response. This is a pathway that cancer cells leverage to provide a survival advantage. It's also leveraged in metastasis. And this particular drug is now targeting a specific factor in that pathway. The actual direct tumor engagement at the receptor level is still kind of being worked out, but there seems to be some very strong preclinical data that would support this, and our hope is that in this ARID1A in the clinic setting will actually lead to some efficacy signal. So if you have this trial open, please continue to screen for ARID1A alterations. Brian, you just had a patient that you were working on that had an ARID1A alteration you were telling me about, right?
Yeah, just this afternoon I was late to rehearsal because we have identified a mutation in ARID1A. It's interesting. It's any type of mutation. This happened to be a VOS, but it's eligible for the trial, so we signed up for the trial, which is it's exciting. This trial's in its infancy, but I know I'm following these patients. Well, one strategy we have in a lot of these patients, we're getting testing done earlier on.
Yeah.
So I think it's one important point is I have a list, basically a tally of those patients that I'm identifying before they're eligible for the trial. I have a list of patients who do have the ARID1A mutation. So if, and hopefully not, but if they recur, we're all lined up to get them onto this trial.
Yeah.
Which is nice.
Yeah, and it goes to shows that
Rob, just nice to see a board question finally make it to the clinical arena. ARID1A, clear cell, great.
exactly. And then, of course, we have our really interesting cell-based therapy of Adaptimmune trial that's looking for HLA-restricted patients with tumors that express MAGE4. This is an intensive strategy that is open in a number of sites that have the capability of doing this. So we're, again, another trial that we're looking for help in screening. This is a trial where screening can be done during therapy, and there are a number of key centers that have this trial open, and so we're hopeful that people will identify those patients and potentially refer them in for further evaluation for this cell-based therapy.
Yeah.
Rob,
So
go ahead.
before you go, I'd like to talk a little bit about these and other biomarker trials,
Mm-hmm.
and what are some of the tips for our audience out there of how we enroll patients on these trials. Because you start putting in biomarkers that make up a small percentage of the population, you have to really screen for these patients very actively. So one of the big things is the pre-screening, right?
That's right.
To actually find out so you can sign these people up for pre-screening. Doesn't mean they're committed to the trial. So important as the case of the last two trials there. But others from the panel, how do we get patients on the Bob?
And I think, Brian mentioned he keeps a tally of all his patients, but you can also work with your, whoever your preferred NGS vendor is, and they're happy to help you in terms of providing you lists of all the patients in your center. So you can also then target the other providers that you work with and say, hey, this patient, has an ARID1A mutation, please consider this trial. So I've used that strategy as well.
Great.
It's a culture of research, though. So in my office,
I love it.
it's every therapeutic decision,
Yeah.
everyone, is this patient eligible for a clinical trial? And then, quite frankly, if not, what do the NCCN guidelines say? So I've sort of trained my MP to come to me and say, okay, what do we do with Mrs. So-and-so? And she's not eligible for a clinical trial, and I love to try to trick her. It's it's almost impossible.
Yeah, exactly.
And then,
That's usually the case,
and then
yes.
she says, and the NCCN gives two options.
Yeah.
Which one do you think we should consider? And then I always say, in the spirit of shared decision making, let's go talk to her. so that works for me. Go ahead, Bob.
Yeah, I think another point is, now that we're doing this molecular testing, it needs to make it into your note, so you're looking
Absolutely.
at it.
Yeah, I love that.
In
Yes.
every visit. And so I
We
put
test
my
everyone.
foundation right into my note, and
Absolutely.
it gets copied into every note, so I'm looking at it.
It's exactly what I do.
Same.
I put the main tumor number one
Yep.
in my assessment plan. Number two for these cancers now, and now it's for cervix now, which it didn't used to be, and now for
Right.
endometrial,
Yep,
which
yep.
it
Right.
didn't used to be.
That's
Right.
Number two, molecular status.
Yep.
And then I can see that we've got the results back, and I put the key findings. I actually put the key findings in there, like what are going to be things that I can move on to.
Yeah.
Yeah. One
Great
other,
idea.
We just do a little screenshot of the findings and stick it right in.
That's cool.
one other point for these rare tumors, I think it's nice. A lot of other doctors outside of our own centers don't want to treat these rare tumors, don't have a lot of good options, and they're really, they want better treatment options. The patient I put on today, Rob, she was being taken care of at a competing institution. I had previously sent out an email to all the local oncologists, Uterine oncologists. This is what we have available. It's a rare tumor in clear cells, and she was sent to me for this trial. And it's one strategy. We're not always going to see these mutations within our own institutions. We really need to partner
Yeah, you
with
do.
our local oncologists, and they want the same thing we want. They want the best treatment options for our patients.
Sure.
There are no good treatment options for recurrent clear cell outside of clinical trials. So it's a strategy that's worked in my practice.
Yeah, absolutely. And we'll talk about this, I think, in endometrial cancer as well. That idea of putting in your narrative, your opening line, to put all of that data there, also it makes it easier to search for as well as when you're trying to find who's in your practice or which of your patients are actually potentially eligible.
I think also it's nice to have multiple trials open. We talked about how the PROC setting is pretty robust, and that's a nice thing to have different options, because some will have no biomarker, they'll be non-specific. They may have incorporated but not for trial enrollment. And then you have some that are specific where you'll have ovarian cancer being a rare tumor and then these subsets being even less common. So I think having multiple options kind of helps strategize this too. I love the pre-screening, incorporating into the medical record, and then we're in a dense area with GU oncology, and I think partnering with our other institutions, and they may have trials open that we don't, and understanding what other profiles there are is really important.
Yeah. And Tom, and I know you're going to talk about this with endometrial, but it's not only tumors that are mutated. Sometimes we have tumors, for example, in endometrial cancer, that are specifically for the wild type, non-mutated tumors. So I think, I know you're passionate about this, to your point.
Yeah, I mean, I think that we think of mutations as being actionable. Sometimes the lack of a mutation is also biologically actionable.
There you go.
That's the key.
And putting that on that second line of the note as well to get them ready for the trial.
Yeah. Exactly. I put P53 status on.
Yeah. Especially in endometrial cancer.
My MA just prints out, I'm just saying, the KRAS report. If there's a treatment decision, she prints out every CAT scan when I talk to a patient because I want to give her a copy.
Yeah.
And if there's a decision, she prints out the KRAS report because she knows I'm going to ask for it.
Yeah,
And it
KRAS or
keeps
Foundation,
the clinic
whichever.
moving, or Foundation, whatever, because it keeps the clinic moving.
That's a lot of trees, Brett.
I was just thinking the same thing.
What?
That's a lot of trees.
What's your carbon
You have
footprint?
printers and paper in your office?
we recycle, so we recycle.
You don't even grow trees out
we
there.
recycle.
Cacti.
I love it.
So I love your next slide that's coming, right? You're going to talk a little bit about rare tumors?
Yeah.
God, that was like a key, let's move on.
Yeah.
Kind of statement.
Thank
Yeah, I
you.
love
Yes.
it.
TV.
I love it. TV, yeah. So we have a couple trials to talk about. RAMP 301. This is a trial looking at a strategy that we've seen success for in RAMP 201. We had objective response. This was reported out at ASCO and at ESGO with a objective response rate of 45%. And this is a RAF-MEK inhibitor, avutometinib, so it hits two places on that pathway in combination with a FAK inhibitor. So this is really interesting because these are not only hitting the signaling pathway in two different places vertically, but it's also hitting a escape mechanism. And so to see this efficacy of 45% in low-grade serous tumors is really pretty impressive. We've had experience with MEK inhibitors alone, and we've got a couple of some great phase 3 trials that have demonstrated efficacy as single agent. But to see that this combination at the rate it was doing and also align with the KRAS. So what do we know about KRAS? Very difficult to treat, right? To target. We have some specific inhibitors out there now in lung cancer working their way through with G12C and G12D soon to come. But this is difficult. It's a poor prognostic factor, as you can see here. But this aligns with the mechanism of action of this drug in that pathway, the MEK pathway, and with a response rate of 60% in that mutated tumor cohort and 29% in the wild type. So that led to the excitement about trying to do a full phase 3 trial, and this trial hopefully will be coming soon, but it's looking at that combination of the RAF-MEK inhibitor with FAK against investigator choice chemotherapy.
Yeah, I think KRAS is a really interesting mutation. Go ahead, and then I'll add.
No, please.
No, I was just going to say, in this disease, it appears to be actionable. We talked about actionable earlier in terms of targets. KRAS mutations in other diseases may not be actionable. It just may be a marker of a poor prognosis.
That's right. Just prognostic, not predictive.
Correct.
Prognostic of, yes, worse chemo response.
Well, that's what I'm saying. It has a negative prognostic factor. Absolutely.
We're really excited about this trial. We just opened this up at our institution, and I think there's 2 points. One, patients could have a prior MEK inhibitor therapy. Yes. And there's crossover. So if the patients are an investigator choice, they can actually go onto the experimental arm if they have progression of disease. I think that makes it a really attractive option for patients, especially in a place where I live where patients travel far. This is a great incentive where they know they have access to that experimental arm regardless.
Yeah. What I'm really excited about with low grades, and it says here rare tumors, historically we were never able to study rare tumors.
Right.
Yeah.
Now we put together between GOG 281, which put MEK onto the map with these tumors led by Dave Gershenson, we were able to look at CDK4/6 in the 3026 trial. That's a series of trials. Now we're leading to the 3097 that we're making the outcomes better for these patients in a rare tumor, something that we were never able to study before. I'm really excited about that. What's next? We're going to do this, and then what's going to be next? Biomarker-driven therapy. So really,
And this is, talk about a disease, the natural history of this disease. We used to didn't really have much options in this disease before, right? But these patients we had them. They were around, and their natural history is this. We don't see rapid progressions. So we have, ways of controlling just the indolent biology, although in some patients it doesn't have that particular pattern. So to have these therapeutic options, I think, has been really exciting. And this particular therapy study also allows us to use endocrine therapy in the control arm. So.
Great. I love the bouquet trial too. I wish we had this open at our site, but I know there was limited enrollment to site.
Yeah, unfortunately that was the case. But again, this was an opportunity for discovery, and this is a global trial, and it is iterative. So these are serial arms coming in based on availability of novel drugs. They're hitting multiple different targets. You can see, although it's not so easy to see, but you can see the biomarkers that are trying to identify particular arms for the trial. And as new hypotheses get generated, new arms come into the trial, so it's continuing to iterate. Just recently, for instance, we had cobimetinib that demonstrated efficacy at ESMO. The report demonstrated 33% in the low-grade serous population of that cohort, and so that will expand. In the atezo-bev arm, there was a 14% response rate, and so the thought was that this was interesting, not enough to clear the predefined criteria for go, no-go. Each one of these has that same predefined, kind of like, Tom, as you mentioned, like in our 126, 146, 170Q in the GOG, these have predefined go, no-go points. In this particular arm, they're adding the cyclophosphamide for that patient population to see whether or not the metronomic dosing for cyclophosphamide.
And that's for those that don't have any particular
biomarker.
Yeah,
Exactly.
biomarker. Yeah.
So I just wanted to share we don't have this study open at our site, but when we have a patient that may be a candidate for this trial, I refer them to Levine Cancer Institute, which is about 3 hours away from Duke, so that patients can have access to the trial there. And I think it's really important for us to act in those kind of selfless ways so that our patients have the opportunity to participate in these studies.
Agreed. Totally.
Great
agree.
point, Angeles.
Yeah. Ultimately, that's the best options to the clinical trial. So I think, for the ovary section, I hope you've seen kind of where the pipeline is evolving. It's very robust. We do have opportunities, so we're open to ideas to where we can enhance the efficacy across the portfolio, the natural history of this disease. I think biomarkers, right?
Bring it on.
Bring it on.
Yeah.
So and I guess this is kind of one of the key things about doing clinical research is that a lot of our exploratory endpoints do involve the exploration process, right? So it's really important that when we design these trials that we put in the opportunity to gather samples. I know you're a strong proponent of this. It's hard to do because it takes time and money and patient acceptance, but that's how we develop the hypotheses for the next trials, and that's so exciting to see. And I hope you've seen how we've been able to leverage those opportunities now with the portfolio that we're actively moving out, right?
Yeah, absolutely. I mean, this is another beautiful story when we're in clinic and help our patients with some of these new drugs. And mirvetuximab's been a game changer, a total game changer. I just wish that whenever I get a FR alpha result back from one of my patients and it's negative, I'm so sad.
Yeah.
So I just want to, increase our opportunities so we can treat all our patients across the spectrum of these different biomarkers.
But when you do have a result that's negative, you can sometimes rebiopsy, and I have
Yes, I'm
found
so glad you brought that up.
Meant to make that,
Yes.
yes.
I have a situation right now where
both for
her,
stro and
yeah,
for
That's-
MIRV.
the
That's right.
mental biopsy was negative, so I'm going back to see if I can get primary tumor.
Yep.
And then if it's, because they didn't think this at the beginning, right? And then if the primary tumor is negative and you have a recurrence later, think about biopsying it, sending it. So we need to collect this data
Yeah.
and continue to share these stories.
Right.
And with the advent of biomarkers, we need to get more used to rebiopsying anyway, because some of these, there can be change.
Yeah, we know
over
there's a lot of
time.
heterogeneity in
Temporal
these tumors.
heterogeneity,
Yeah.
spatial heterogeneity, all those things that figure into that. So we need to become more facile in that and put that into the expectations for the patient. Because
Right.
if you start building that out all along, oh, we might have a trial for you. I think that really helps them embrace that.
Going to drop a big teaser here with a little bit, like a minute left. But anyway, if you look at the other solid tumors, there's so much blood biomarker data.
Yeah.
Like they're doing a lot of blood. We're not. FR alpha is really hard apparently to detect in the blood, so that's not a good example. But I do think we need to look at different biomarker opportunities, not just about the tumor, but we really need to be exploring ctDNA.
And there's also antigenic decay. So
You're right.
in cervical cancer, as you remember, 826 had 11% negative rate
Yeah.
for PD-L1, but in 18 is only 5%.
Right.
So a fresher biopsy was more likely to have intact antigen, and you have the negative rate.
Right.
So just what you're saying, rebiopsying, heterogeneity, but also the age of the specimen is also relevant.
Let me just redirect here for 20 seconds. An important trial we didn't talk about, Duo. Impacting, should it be impactful in your practice? What are you doing with that data?
I'm not utilizing that combination in clinical practice. I just
why is that?
wasn't. I think that for me, it wasn't really convincing what was the additive benefit or that there was any synergy of adding the PARP inhibitor or adding an IO to the PARP inhibitor combination.
So more than 1,000
I wasn't
patients
convinced.
in ovarian cancer, frontline, based on Mediola. Mediola was triplet, olaparib, durvalumab, bevacizumab, but in recurrent, no chemotherapy. And so Duo, same maintenance strategy. Triplet was the standard, carboplatin, paclitaxel, bev, versus the quadruplet, adding durvalumab, versus the quintuplet, durvalumab and olaparib. Again,
Right.
all arms have bev.
Right.
And they didn't, just what you said, Angeles, the quadruplet did not get compared to the quintuplet. And they say, well, we didn't have enough patients, or maybe we should have. And then they do a further subset analysis in the HRD test negative. So that's why you said what you said, obviously, is that based on the way the study was designed, it missed its primary endpoint, or it missed a practice-changing result,
There you go.
even though it showed,
It didn't miss its primary.
It was a
endpoint.
positive
I hit
trial.
its primary.
corrected
Yeah, he
myself.
corrected.
Yeah.
even though it showed that the addition of olaparib to bevacizumab worked. Oh, you mean Pala-1. That's
Yeah.
right.
Right.
Yeah, that's the thing I
And
struggle
sort
with.
out the contribution.
Yeah, I struggle because, and also talk about the iterative history, right? So we have the chemotherapy plus an IO, which was a negative trial. We have the chemotherapy Bev IO, which was a negative trial. We have the chemotherapy Bev PARP, which was a positive trial. And then we have this, and it's really hard to.
Right.
Right.
Sounds like Duo-E, doesn't it? Oh, it's done by the same guys. Sorry.
Now,
We're
come
going
on.
to be talking about Duo.
All right.
All right.
Great
Yeah, in a
segue.
minute. We'll get there. Yeah.
So first of all,
Yeah.
Angeles, Rob, thank you. You took us through an amazing amount of data in a short period of time. And I don't know if anyone noticed on the agenda, but we've actually given less time to ovary than we did to cervix.
It's like a first
and,
ever,
and
right?
to endometrial, which it's always the opposite. So there have just been so many crazy exciting data sets that have come out in cervix and uterine. And to lead us into the uterine cancer discussion, looking at the known knowns, the known unknowns, the unknown unknowns, and everything else, will be Dr. Brian Slomovitz. Brian?
Thanks, Tom. And it's really, a privilege for me to be the uterine cancer clinical advisor for the GOG partners. It's been such an exciting year. Really, I would argue the most exciting year for uterine as opposed to the other cancers, but that's our little. That's our little
Cervix is all right.
I think so.
I would argue that uterine cancer
Come
is,
on.
but that's for another day. So, we're going to talk about changes in the front line and the second line. So many exciting things going on. Let's briefly go through the history here. Chemotherapy has been the standard of care in the first line management of metastatic and recurrent disease. Based on the work of GOG 209, led by Dave Miller, carboplatin and paclitaxel became the preferred regimen. Here we saw progression-free survival of 13 months, an overall survival of 20 months, response rates of 52%. And when you're sitting at home saying, wait, these curves are the same, the outcome here wasn't to increase the efficacy. The outcome here was to limit the toxicity. The prior treatment option was the TAP, the triple with adriamycin. So we wanted to get away from that with an easy regimen. And I'll congratulate Miller and his colleagues for getting this published in the JCO in 2020, but it really changed the standard of care and helped us establish what the control arms will be moving forward in our trials. I want to jump right into it. In a Monday afternoon in March, Ramez Iskander, one of our colleagues here in the GOG, presented GY018, chemotherapy plus minus pembrolizumab for the frontline management of recurrent or metastatic endometrial cancer. This is the one trial that looked at DMMR, powered for DMMR, and powered separately for the PMMR group. On the same afternoon, Mansour Mirza presented Ruby. Similar trial, chemotherapy plus minus dostarlimab in the same patients with recurrent or metastatic endometrial cancer. And finally, most recently, the ATTEND trial, similarly, chemotherapy plus minus atezolizumab in the same group of patients.
So 2 of these trials at the SGO.
Monday afternoon
Right.
at SGO.
Yep.
Yep.
Return for 2024 at SGO. There'll be more exciting developments.
Thank you.
There's some
Says the prez.
team players here. Angela Secord is the president of the group, and Bhavna Pathuri and Matt Powell, the program chair. So we look forward to another exciting meeting, and it should be more exciting than the last meeting. This data is really tough to beat, which we're excited about. So first, I want to talk about the DMMR settings, and this is a slam dunk. Look at these survival curves. I will argue, and I would win, that this is some of the strongest data that we've seen in gynecologic cancers. The hazard ratios here are just as good, if not better, than PARP inhibition in BRCA-positive mutated ovarian cancers, which was a game changer for those patients, and this is a game changer for these patients. Look at the separation of curves. You know, Rob's our statistician in our panel, but I'm not that smart. I'm not that good of a statistician. It's not a one-finger rule in between curves. It's like a three-fingered rule in between curves. Gee whiz, in the DMMR, deficient in MMR, remember, you know, biomarker-driven trial, deficient in MMR, hazard ratio of 0.30 in GY018, favoring checkpoint inhibition. Similarly, Ruby GY hazard ratio of 0.28, and similar hazard ratio seen here with ATTEND. Complete game changers. You know, does anyone? I want to keep the discussion here very brief. Is anyone on stage not going to use a checkpoint inhibitor in the management of DMMR patients? Dr. Pathuri.
No, of course I'm going to use it.
I saw your hand raised.
No, I was going to add that, you know, unlike ovarian cancer, advanced ovarian cancer, you know, the median survival in that group of patients is much longer than the median survival in advanced endometrial cancer. So, you know, as you stated, this benefit is really, really important, you know, a hazard ratio of 0.3. So I just wanted to echo that point.
Complete game changer. Now, what would really one of the things I really want to do in my career is to eliminate chemotherapy. We know in colon cancer, they did the trial chemotherapy versus a regimen without chemotherapy in the management of their disease. It was positive. Look at the 2 trials that we have here on the left. Keynote C93 completed accrual in the DMMR population, chemotherapy versus pembrolizumab alone. Completed accrual, hasn't read out yet. Similarly, the Europeans, EN13, are looking at dostarlimab versus chemotherapy in the same population of patients with DMMR. Little teaser here on the right, LEAP-001, not a GOG trial, but also completed accrual in the PMMR, which Rithu's about to talk to us about, lenvatinib pembro versus chemotherapy. We're going to have our discussion in a little while about immunotherapy in the first line overall, but how great would it be, right, if we can get rid of chemotherapy in the first line management of this disease with better efficacy? You know, and we're really hoping for that as we move forward. That was the MMR. Not a lot of argument there, which is nice. But Rithu, why don't you take us through a little bit of in the PMMR population, some of the same studies and where we're going and what the opportunities are.
So Brian likes to take on arguments that he knows he'll win. It's easy. This is a little bit more challenging. So
more nuance.
no, it's actually really exciting to present the data in the PMMR subgroup because I think it actually does warrant a lot of discussion. And so you heard a little bit about GY018, and here it did meet its primary endpoint in this cohort as well, where you can see a progression-free survival advantage in the patients who received pembrolizumab. And we also saw an advantage in the RUBY PFS PMMR. This was not an analytic endpoint here. This was as part of the intention to treat, but this was a subgroup that they analyzed, and you can see the hazard ratio favored those who received dostarlimab along with chemotherapy and then dostarlimab maintenance. And then, as alluded to, the ATTEND study. Now, ATTEND is a PDL1, so I think that's always an important difference to recognize, but really no difference between these two populations here. And so I think this is interesting. We have kind of some separation of curves here, and I think this represents that the PMMR group may be a heterogeneous tumor, and we'll talk about that a little bit more as we look at molecular subgroups. Now, this is not meant to be prescriptive, so this is just kind of to engage us in discussion here. But Mirza at ESMO this year presented the subgroup analysis, which I think was really provocative. And the POL-E mutation, the curves are actually on there. It just doesn't look like it because they're completely straight lines. Small subgroups here, you're looking at 5 patients, yeah, but no recurrences in this group here. And so really, whether immunotherapy or even chemotherapy is necessary for another day. But what I do want to highlight are the other subgroups. As mentioned, slam dunk, we know the DMMR population benefits from the addition of checkpoint inhibitor. I think the two groups on the bottom are the ones that are probably more interesting to discuss. The P53 mutation group, where you can see a PFS benefit in this subgroup. Now, remember, this is just kind of hypothesis generating, hazard ratio of 0.55, and then the non-specific mutation profile subgroup, which is a hazard ratio of 0.77, maybe, and kind of the confidence interval not as favorable here, but I think these are the two groups that warrant discussion. I will say they also presented overall survival data, and it really mirrors the PFS. Really, the P53 mutation group, DMMR group, really had a profound difference with the addition of the checkpoint inhibitor. The P53 wild type or non-specific mutation profile group really didn't. So I think this is the area that I want to focus on. And just to muddy the waters a little bit more before we move on, the role of PARP inhibitors. You heard about DUO-O. Well, I'm going to talk a little bit about DUO-E, which is looking at this combination of PARP inhibitor with olaparib in addition to durvalumab. So now we actually have 4 trials looking at checkpoint inhibitors in this population. And then RUBY trial part 2, which is a completed enrollment, and we're waiting for those results, which is looking at dostarlimab plus niraparib in this cohort. So our dear friend Shannon Weston presented DUO-E, and here you can see the PFS data here. The intention to treat population listed on the left side, and you can see that there's the 3 survival curves. I will say the control arm, which was the carboplatin paclitaxel, is what's compared. So that's what Durva was compared to, and that's what Durva and olaparib were compared to. And then you can see the PFS PMMR cohort, which was a majority of the population, as we saw in all of these studies. And here you can see that there is a benefit here with the addition of durvalumab or durvalumab and olaparib when compared to the control arm. Now, how we use this in clinical practice, I'm curious to see what the panel here does.
You.
Well, I'm presenting. This is my turn. So I'm curious to see.
I think you should ask Brian.
All right. Dr. Slimovitz,
Yes.
are you going to incorporate this if you haven't already?
Yeah, no, it's a great question, and I'll answer it. I have not incorporated already. I still think that we need to learn more of the combination of PARP inhibitors and maybe identify those patients that would benefit from PARP inhibitors. I know there's going to be some patients, but we don't know which ones. We discussed this at IGCS. We had a nice panel, and I asked Shannon specifically the question, where would you use this? And I think her answer was spot on. We need to do more translational studies. We need to identify biomarkers. Maybe it's an HRD, maybe it's a sort of variant of HRD, which will benefit from PARP inhibitors. But yes, it will be a part of our practice. We just need to figure out which patients.
I love it.
And I just want to make
Go ahead.
Yeah, one comment. So I think the critical analysis here would have been, the Durva versus the Durva and olaparib, right? And it was done here, but it was not a pre-specified analytic endpoint, and it would have been
Like
really,
DUO, you
really
mean.
nice.
Well, this is a little different than DUO though, because Durva is the added drug that you need there, right, with the chemotherapy, and this just shows a potential benefit of adding or layering olaparib on top of that. It's a really small
Right.
I'm not, but it looks like there's something there. But I totally agree. I want to know a little bit more about the
don't know.
underlying biology.
I don't know
Yeah.
if it's just the olaparib.
So one of the things they did in this trial to try to sort that question out was to look at DNA damage response genes and their alterations to see whether or not there could be some benefit of the olaparib. But I think it's important to really think about this the way we did in ovarian cancer. The story of ovarian cancer 2009, started from preclinical work done 4 years before that showed that there was that the occurrence of a BRCA mutation and the use of a PARP inhibitor had synthetic lethality or synthetic sickness. Those cells were hypersensitive in the two conditions. I don't think we've done enough homework in endometrial cancer to understand if that's even the same, if that even exists. And so when we did the screen in ovarian cancer, we looked at 30 different genes and realized that about 5 of them actually have profound synthetic lethality. The other 25 of them some of them have absolutely no synthetic lethality, although they're important in the DNA damage response process, but they're not independently dependent. So I think what's going to be done here, and I applaud the company, AstraZeneca, that's trying to go through this, because they're going to spend some time to understand whether or not there is a synthetic lethal in endometrial cancer with a PARP inhibitor to try to understand how this might describe what we're seeing here clinically.
But the biomarkers weren't collected. The number of patients that actually had HRR gene testing was low. The missing data was high.
Yeah. Well, like I said, it's an exercise that they'll do post hoc. But again, what we need to. But again, we can do this outside of the clinical experiment. We can do this in the lab to start to understand what the process is. But it doesn't work if it does not synthetic lethality.
So my frustration here is my sense, and I don't know, but they didn't think that they had confidence, whoever was running the study, maybe the PI, maybe the sponsor, maybe the steering committee, that there were enough DMMR patients, which then it was wrong.
Yeah.
So if they would have had so they didn't even sort out DMMR, PMMR.
Yeah.
The next thing is the science that you described. Is there really an opportunity here? They were sort of hoping that platinum sensitivity
would have been the
would
surrogate.
have been the surrogate rather than a molecular signature. And again, the tissue collection was inconsistent. The confidence in the DMMR opportunity was not there. And we'll have to see what regulators say. We'll also have to see if there's a halo effect from Ruby Part 2.
Yeah.
Brian, I don't know if you're going to talk about Ruby Part 2, because Ruby Part 2 is a very important study, but suffers from the same sort of inferential, proportional weighted.
Right. How we yeah.
Yeah, I was
Two
just
different-
gonna,
Can I just ask, all of this aside, if this gets approved, are you going to use it?
I practice according to labels and guidelines. I think the better question is, what's the chance of it getting approval? And obviously we don't know, and
We
we've
don't
sort
know
of
that.
addressed that. I'm not optimistic.
Let's say it gets approved.
Say it
What
does.
would you do?
In some settings, I know that's not answering the question. One of my patients on this trial has a germline BRCA mutation.
Yeah.
Right?
Yeah.
And I didn't even really understand that germline BRCA was as big of a deal as it is in uterine serous cancer. And quite frankly, I thought she had ovarian cancer when I operated on her, which is what the presentation was. And
That'd be kind of a no-brainer, though, right?
Yeah.
right, but
yeah.
it was endometrial.
Yeah.
Yeah.
And
Well,
then when
still,
yeah,
it would make sense based on this data. That'd be the group most likely to
but that's
benefit.
the idea. So I think there's going to be some no-brainers, Tom. But I
Maybe
think
that molecular analysis will help us.
right.
Right.
I think
Subgroup.
I see this a little bit differently. I see there's a potential signal there, and I wanted to learn more about it.
Yep.
What excites me is that we saw such great results with patients who have DMMR with endometrial cancer, and we're helping them and seeing a substantial benefit. And I would really love to be able to offer our patients who have PMMR disease that same benefit.
Yeah.
I don't know if this is the right answer yet, but I think that we should be careful and explore more before we just write it off.
Subset of a subset. That's tough.
No, it's not a subset of a subset. There's a signal there. We need to do more to explore it. There's also another trial out there, I don't know if you're going to discuss it, that's evaluating olaparib only, that may be concerning in certain subsets. So there's a lot to learn here about endometrial cancer
Well,
still.
Utola was a negative trial,
Yeah.
so we can call that out. And then a subset is PMMR. That wasn't planned.
Right.
That's the subset number one. And then subset of the subset is arms 2 to 3. So it is a subset of a subset.
Right.
And is there a signal? Maybe. But
Brad, there's something there, even if it is not pre-specified there. And you always talk about hazard ratios.
It met its endpoint.
As long as I've known you, you talked about hazard ratios. That lowest hazard ratio is comparing versus Durva, the Durva elaparib versus Durva, and it's 0.76. Does not straddle 1. There's a signal, and we need to look
I
at it
think
further.
that's fair.
But it
But
wasn't
that's a
meant to look at
subset.
the
You're
two.
Yeah, I
right.
agree.
That's not
Subset of a
I know,
analytical.
subset.
but there
Yeah.
is a signal
What
there.
we mean by a subset of a subset, I know you get it, but it means that the comparison populations, okay, that the difference, which you nicely described, maybe by chance. Because if the populations are not sort of similar, and that's what we use stratification factors for, then we can begin to say, oh yeah, there's a signal. But the question is that difference that you nicely, is it based on differences in the population that were not controlled for in the trial? Because again, multiple comparisons.
This was all randomized, though. But I do think this
That's
is
the
a
key.
great biomarker.
Say it again.
I'm trying.
Say it again.
I already said it once.
Say what?
that
No,
it-
it's the multiple
It's
comparisons,
the
right?
multiple comparisons and the differences in the populations that lead to false discovery.
Correct.
And whether there's a signal or not, I get it. Does it deserve to be studied? Yes. But the issue is, will we do what our mission is to evolve the standard of care? And I don't think this study does that. So I don't think we need to. It's helpful to argue whether it's a signal or not. The question is, are we going to change standard of care? And did this trial do it? Unlikely. And I think, Brian, is Ruby 2 going to do that? I mean,
It's a great question. It's a short answer. We don't know. It's a little difficult there.
It'll
but
be
you're
inferential
comparing,
too, because we'll have to do the
same.
cross trial, and it's going to be tough.
and it's a secondary. They divide it into a separate study, which I think, to this credit, it's all in the same trial. They're looking at it, and they're going to have to add some control arms into control arm patients into Ruby Part 2. So, I mean, subset of a subset. Aretha, can you go to the next slide?
Sure. Well, I was just going to say, this is, just for more thought-provoking discussion. You guys are monopolizing my time, but I love it, actually. I love it. But you can see the HRR mutation status is on here. But, I think, and Rob, you've always reinforced that subgroup analyses are not meant to be practice changing. We should not change our practice based on certain subgroups, because every patient is on every bar or every category here. But there are always some things that I think stand out that might warrant further discussion or evaluation. So, Tom, I'm going to ask you, what are your takeaways looking at the subgroup analysis?
Yeah, I mean, I think it largely reinforces the trial, right? And most of those points lie to the left of Unity, and it's consistent with the overall findings, always, something that's helpful. I do think the thing that's interesting is the Asian population. Does that mean the next Asian patient that came in, if I were using this regimen, would I not offer it? No, because we don't know enough about what other factors were involved with that. However, I believe it was in Attend 2, we saw a trending towards it not working as well. So are there other factors that are involved, whether it be pharmacokinetic, whether it's
Biomarker expression.
scoring, whether
Mutation.
And it's region,
could it
not,
be TPS scoring for in Attend?
it's
for
region,
example?
not race.
Region of the
So,
country.
Just
Yeah.
to clarify.
Yep.
Right.
Right. Yep.
And I think this adds on another biomarker question
Exactly.
Yeah.
Yeah.
with the PDL1.
Right.
So,
Exactly.
and in DOE, they did show PDL1 data, but they didn't look at it with MMRD status
Right.
analyzed.
As
So
you
it's
start
really
cutting and
confusing.
cutting and
Right.
cutting
It's really
and cutting.
confusing.
Yeah, I'm
Yeah.
sure it's coming.
So I want to move on to maintenance therapy. And, I think this is something that we've been using in ovarian cancer now with the PARPs, and cervix cancer now with Pembro and Bev. And I think finally in endometrial cancer, we're seeing some potential avenues for this. So I want to just talk about, I'm going to focus on the P53 wild type. So we talked about how we know DMMR is clear. P53 mutation status, I think, is still up in the air, whether immunotherapy is right for those patients. But I want to talk about two agents here, selinexor, which is an XPO1 inhibitor, and navtemadlin, which is an MDM2 inhibitor. And both of these restore P53 mediated apoptosis. So they keep P53 in the nucleus. And I'm going to focus on SIENDO because we have data from here. And in the original trial that was presented, and just published this year, presented a couple years ago, published this year, the PFS in the intention to treat group, which was a primary endpoint, really wasn't remarkably different. You can see selinexor versus selinexor in the blue line and placebo in the red line. And you can see that the hazard ratio crossed, the confidence interval crossed 1. But they had this pre-specified subgroup, and this was a P53 wild type. And here you can see that the selinexor, patients who received selinexor maintenance actually had a significant hazard ratio or PFS benefit with the addition of that maintenance therapy compared to placebo. And Brian actually presented this long-term data at ASCO this year, and here you can see the P53 wild type. Selinexor had 27.4, placebo 5.2 for a hazard ratio of 0.42. So really kind of something astounding, I would say. And then the P53 mutation group, really no difference in that population. So this was very exciting, and this has led to the phase 3 or confirmatory trial looking at selinexor oral maintenance therapy after treatment with platinum-based regimen. Now, these patients can be in the front line in a stage 4 or recurrent or advanced disease, or in the recurrent setting, and they are allowing for prior checkpoint inhibitor. There's also a study looking at Madeline, which is also open, and both of these studies are accruing. And I think this is a great option for our patients with P53 wild type endometrial cancer. So we have one of these trials open. We're really excited about this, and I hope others are as well. Before we move on to the next topic,
Well, one thing, I think as we wanted to talk about, the biomarkers question that we brought about, we've all been talking about mutations.
yeah.
Mutation.
This is where it comes
overexpression,
back to Brian.
Mutation, right, yeah.
Endometrial,
And we said, okay, well, actually we have an actionable alteration, which is wild type. And so, I mean, that's just something we don't talk about all
I
the
know.
time,
I think
right?
that's a great point. And
Yeah.
I think, we're going to incorporate P53 mutation status into our staging system now as we slowly start adopting that. So we're going to be checking this. So this should be on everybody's radar.
Yeah.
Well, this is also for the group, and you brought this up in one of the other subgroup analysis of the Ruby trial is the NSMP group, which is more likely to have wild-type P53.
Right, that's exactly right.
So this is a great opportunity for those patients.
Yeah,
Yeah,
well,
it's an unmet need, apparently. Yep.
Yeah, so when you're sitting at home, you're thinking about what should I do tomorrow? What do I need to do? First thing is we know that the best way to treat patients with cancer is to put them on clinical trial. So Rita, to your point, if you have one of these two trials open, the Export GOG 3083 or the KRT 232 GOG 3089, the first thing we need to recognize is yes, there is an unmet need in the pMMR patients, particularly the ones who are P53 wild type. And if you can, we want these patients on trial. We need your help to put these patients on trial. And we may see in the P53 wild type patients who are getting selinexor, we may see a difference like this, which is 27.4 months versus 5.2 months. This is not to discount the data that you presented earlier in the pMMR patients who are even the NSMPs who in those centers that don't have the clinical trials available, yes, checkpoint inhibitors is ready to be incorporated into standard of care. Again, it may be an unmet need, but if you don't have a trial open, we do believe, we're not arguing against that data, but we just think it's an unmet need that needs further evaluation.
I was a little skeptical in the 2-month improvement in progression-free survival in Ruby in the pMMR subset, but the October 30th press release by the sponsor of Ruby, which said that it met its primary endpoint of DMMR, OS, and the next endpoint carrying down, intent to treat, OS, and then it also said, although a subset, granted, that the pMMR also was statistically significant and clinically relevant. And you can sort of look at the way it was tracking in the March 27th New England Journal publication that it was likely to be substantial. I don't know what it is. It'll be presented at a meeting, but the fact that the sponsor, with all of their lawyers and governance, would come out and say, look, there's a DMMR intent to treat and even a pMMR OS benefit. I'm using, Brian, to your point, I go to the second line. Carboplatin paclitaxel, not weekly paclitaxel, doxorubicin, which was the control arm of 775. I treat again with platinum taxane, okay, and if they're P53 wild type, as assessed by IHC, because that's what we do routinely, then I send it to Foundation, make sure that they are indeed wild type, and then enroll them in whatever trial is open at the site.
And that's another time to highlight the pre-screening. You can send
That's
this
right.
in early and while the patients are getting chemotherapy and assess their eligibility for this.
And we're all clinical trialists. Is anyone here on the panel, if you have a P53 wild type tumor, and if the trial is open, and if you discuss at length with the patient and they're interested, is there anyone here that would not offer them this clinical trial? I don't know, Brad,
No,
you
I
talked
just think I just think.
Oh,
I
bro.
was gonna say is I think that the reason I like these P53 wild type tumors that and these trials that are focused on them is that they do reflect a mechanism of action that aligns with what these subgroups are intimating. Right. I don't know that it's hard to say, hey, listen, we have a subgroup, a PMMR subgroup that has a OS benefit from a press release.
It is tough.
What?
It is tough.
It's hard.
You know, it's hard. But if the magnitude of a benefit of aligning the biomarker of a P53 wild type with one of these types of drugs is so much greater.
But they're randomized to placebo, man.
But I think what you're talking about is
No, no.
biological plausibility.
Biological
So
plausibility.
when you have a
Randomized to
subgroup
placebo.
analysis.
Yeah.
you-
But yeah,
like
but
And you can give them this trial.
well,
on the
they're
next
well
line of
the other
therapy.
trials are also randomized to placebo.
But
No,
Brad,
but-
that is
That's not what I'm
currently
saying.
the standard of care, right?
But triplet therapy is not randomized, so you can give them triplet up front, and then the next line of therapy, give them this. So the question, Brian, that you asked, you know, would we discuss the clinical trial always?
Always, yeah.
But would you?
Didn't you say you always treat per label? Didn't you say you always treat based on label?
So I label and guidelines, right? I said both, right? And this is NCC.
Said you're a
you said
label
label.
guy. You
For
said
one
label.
thing.
guidelines.
We go back to the
You might
recording
have
if
been
you want. You
thinking
said label.
both.
Throw the flag.
You might have been thinking.
Throw the red flag, right?
Exactly.
But the point is that would you feel comfortable randomizing a patient in the front line in the PMMR subset to a placebo? And I think that creates some discomfort for me.
Okay, that's fair.
And that's fair.
I mean, I don't disagree with you. I personally believe that it should be that, but that's
And that's the discussion,
yeah,
shared decision
exactly.
making.
Mhm. Exactly.
Yeah, I think I mean that's. I would put the patient on one of these two trials.
Fine, I love it.
Unmet need. We need.
And you're doing it, and I see it, and I'm so proud of you, Brian, for driving
Don't
this
be so
work
proud.
forward.
I agree with Brian. I would
Yep,
do
we
the
just
same.
opened
We
one
have
of
this
these
trial
trials
study.
a
Yeah.
week ago, so we're excited.
Good.
And
Yeah.
there's an unmet need there. And we can't act. Today is different from seeing the data. We can't act on a press release.
Yeah.
Can't do it.
The other
But-
thing,
And we don't have an approval yet in the PMMR
I hear you.
subset.
And
I
acknowledge
just
it,
want
and
to
I
say
respect
something.
But no, this is the kind
This
of
is,
dialogue
this
that
is
goes
what we're
through.
trying to
and I
do
want to say
here.
something to your point.
Yes.
We don't
So
even do it off a
earlier-
presentation. We just say we want to see the paper.
Earlier, Rob talked about hazard ratios, and you don't like to look at hazard ratios. This is a hazard ratio of 0.4, which is still very dramatic. Or, I'm sorry, that you don't like to look at medians. But I think that these things do not exist in a vacuum alone, and so
Yeah.
I actually take it all into context. When you have a median PFS of what, 25?
27 months, which is
27 months
longer
versus
than
5
overall
months is
survival.
crazy
in this disease?
You know, that is huge. You know, so when I look at these curves, I look at hazard ratio,
sounds
the
like a
formation
park.
of the curve, as well as the median PFS times. But also, I love to do landmark analysis at a 12-month time point and a 24-month time point.
Yeah, I agree.
Well, you know, before we leave the maintenance idea, you know, let me ask you guys, in Ruby and Attend and in GY018, in the DMMR population, we saw almost no split of the curves during the combination with chemotherapy. So the question is,
Right.
should we be doing maintenance only in those patients for DMMR?
Never be
Great
answered.
point.
It's a good question.
Yeah.
I think that's a really good point.
It's a good question, right? I mean,
I think that
It's rooted in the neoantigens that are
I hear you. I
Right,
mean,
with
that's,
the
that's the argument I
chemotherapy.
say, but
Yeah.
yeah.
Got
you
it.
don't know what it's priming.
well, I don't
Yeah.
know. Here's
Antigenic
my
cell
thing.
death.
It goes back to Brian. My thing is, do they even need chemotherapy?
There you go.
I love
Boy.
Well, you'll never know that either, right? Because the control arm of C93 in Dominica is doublet rather than triplet.
Yeah.
But I think that we're already.
But if you're
seeing, like,
seeing really profound responses, we're going to change our practice.
Okay.
And it's also a quality of life issue.
We'll
right?
talk-
Who
we'll
wants
talk
to lose
when-
their
Oh,
hair
man, I
and get
love it.
toxicity?
We'll talk when Ruby PMMR gets FDA approved.
Yeah.
And we'll talk when we're doing inappropriate cross-trial comparisons of C93 and
Yeah, of course. Absolutely.
GY018.
But we
We're
have
not
to
saying
make
you
these
don't have
patients.
to do it. If it's
Brett, Brad, we can't look at these patients line by line. We have to look at, and if they go on C93, and if we do cross-trial comparison, and we do it, they could still get first-line chemotherapy afterwards.
That's right.
Right.
That's true. I like that.
Well, it wouldn't
Yeah.
be first line.
I'm so
But
excited
before-
about
We're
this.
chemo naive.
I know.
abstract.
I know.
Right.
So, you know, it's.
This is the preempt for the next highlight reel.
Yeah. Awesome.
Well,
I
I was just
didn't-
talking about the next highlight reel. We need 2 hours for endometrial.
Exactly.
And I didn't
So-
show it, but DMMR patients also who are P53 wild type also had a benefit from selinexor in
Yeah,
the
that's
SIENDO
right.
trial.
That's right,
So
in that
I think the sequence is going to be important moving forward.
Yeah, no, it's so exciting. You know, for completeness, I wanted to move on past the first line, go to the second line. We know if we get a patient in our clinic today, we know what our options are, not what we're going to do, but what our options are. But there's still a lot of patients out there that have been treated previously and may recur, and I want to touch briefly on second line therapy in the checkpoint naive patients. Here, you know, we see a class effect. In the DMMR population, Keynote 158, led by our good friend Dave O'Malley, demonstrated an overall response rate here of 57%. IO naive, second line after chemotherapy. And we're seeing similar activity with durva, dostarlimab, and avelumab also had some activity in this setting. So I think, again, this is a no-brainer. If you have a second line, a recurrent patient who has, with DMMR tumors that's not received a checkpoint, we need to get that in. But in the non-biomarker population, and I'm just here to review some of this data quickly, non-biomarkers, checkpoint alone is not enough. Keynote 28, again, looking at studies with durva, dostarlimab, avelumab, 3 to 13% response rate. So we need to do more. Now, based on the work by Vicky Macker and colleagues, looking at Keynote 775, here's the difference here. And Brad, to your point, I'm not sure what we're going to find, but if we don't give checkpoint in the first line setting, we have Keynote 775, which shows an overall survival advantage of lenvatinib and pembrolizumab when compared to traditional chemotherapy or investigator choice chemotherapy, weekly paclitaxel, or adriamycin. I always say here, it's not liposomal doxorubicin. It's the adriamycin, which is more active than liposomal doxorubicin in patients with endometrial cancer. Please don't forget that. But it's an overall advantage. So we have lenvatinib, pembrolizumab, and what we've talked about earlier, and what I'll always say, these two areas, the lenvatinib pembro in the pMMR population, biomarker-directed DMMR IO therapy, it tells us that all of our patients with endometrial cancer, at some point in their treatment, deserve either single-agent immunotherapy or immunotherapy in combination with lenvatinib as a treatment strategy here, which we're really very, very much excited about. I'm not sure if there's a lot to talk about here. IO naive patients, I think it's straightforward. Rob?
One thing I just, for people that are, especially our learners, this is a really good trial. It says the same as Keynote 826. It's a really well-designed, well-thought-out trial with really nicely done statistical analysis plan.
By the same people.
Yeah, true. But it was just really, it's just one of those things, if you read the trial and you see how they did it and how they controlled for all the potential variables, it was just really done well. I use this as a good document to say, hey, you want to learn how to do a phase 3 trial and how to analyze it appropriately. This is the kind of stuff that you want to look at. All of the 10 points were hit. 6, it's just really, really well done.
Yeah, and to that point, we're going to, I'm sorry.
I was going to say, I thought this was a really well-designed trial. I agree with you on all your points. The key thing for me with this trial is only 4% of the patients were black. And for me, almost 40%, maybe even more of my patients are black. And this was a turning point for me in terms of, we need to do better with enhancing diversity across clinical trials and making sure that we improve. And Bhavana, you're leading this. You're a leader in this. Inclusion, equity, diversity, and access to care. So I give them really high props for getting this trial done. However, I also think when you take this study to the real world, is it generalizable to all patients?
That's fair. And to their point, this company spent time in their next trial addressing that point when they did A18. It was, again, I think it's a really good story here, but you're absolutely right.
No, that's a great point. And Rob, to your point about the design of this trial, we'll see in a couple of slides, their next trials are using a very similar design. It's in the public domain. We'll talk about that soon, but Brad's leading a trial for the GOG looking at that. But so IO in the second line, if they're IO naive, it's clear. Bhavna, please, we need help. What are we going to do next? And those patients pre-treated with IO, or sorry, first line getting IO, what are our options?
Yeah, I mean, unfortunately, we don't have a lot of data in this area, and it's really important that we understand the efficacy of checkpoint inhibitor after checkpoint use. This study of cabozantinib with nivo that was done by Stephanie Leroux had a prior IO cohort. It was small, 20 patients, but the objective response rate was 25%. In addition, very early data that was just presented at ESMO in 2023 looked at an anti-TIGIT with nivo, and they also saw some preliminary efficacy activity. So I think these two just highlight that this is really an unmet need, and we need to study this area more, which brings us to this trial that you are currently leading. So why don't you tell us a little bit about it?
Yeah, no, thanks, Bob. And
Please enroll. I love that. Over the left side.
yeah, please enroll, please enroll. GOG 303, Podium 204, the sponsor here is Incyte. They have their checkpoint inhibitor, which is, I hate these names, relifatinib, that it's a 5-arm trial, which was really looking to see what we can do in a lot of different settings. The first 2 arms are in IO naive patients. We haven't been able to accrue that well in the US because we have 2 FDA approvals in this setting. But there's only 8 patients. They've hit 92 of their 100 patients. We need more. If you have it open, if it's a good clinical trial patient, please consider that. But it's the last 4 arms that are something that we're really, really excited about. IO after IO, to your point that you alluded to. Arm C, relifatinib and combined with epicadostin, IDO inhibitor, was in biomarker negative selected patients. We need more data. This trial was actually an IO after IO study, and it was negative. So we need to do better there. It's not reported in the literature yet. We haven't published it in the meeting, but there was a letter to investigators, so it's in the public domain. Negative trial. So if we're going to do IO after IO, we need to do something better than this. Based on that, Arm C closed negative, and Arm E, which was looking at a similar combination, another subset, closed because of the lack of accrual. The 2 arms, however, we're excited about, biomarker driven in the FGF mutated patients, looking at checkpoint and pemigatinib in the patients who had prior IO. It's accruing. We need more help. But this may be something that supercharges that IO previous effect to be able to give IO after IO. The last arm, Arm F, something we're very much excited about. In those DMMR patients, MSI high patients that do recur, we know that IO works very well in the first line setting. We're adding the checkpoint inhibitor to an anti-LAG, anti-TIB antibodies in that setting. Arm opened recently, but we need help accruing. And again, how cool would it be to get rid of chemo in the first line? How cool would it be to get rid of chemotherapy, not only in the first line, but in the second line as well? So we're looking forward to answering this question. Bob, and I'll turn it back to you for other options.
All right, so, WEE1 inhibitors, we talked a little bit about it in ovarian cancer, but there's data in endometrial cancer as well. The largest experience is the Adagio trial that had 167 patients, and the overall response rate was 24% with a median progression-free survival of 5.3 months. However, this trial, there was a lot of toxicity, namely neutropenia, diarrhea. So really looking at ways to kind of improve upon this. Other WEE1s are being explored, and ZNC3 is one that was also presented at AACR, 27% objective response rate with a median progression-free survival of 9.9 months. And this trial with this agent also has had issues in terms of dose optimization, in terms of tolerability. However, we now have a dose, and this is the trial for accelerated approval, a single-arm phase 2 trial looking at ZNC3 in uterine serous cancers that are recurrent or persistent who have had prior IO. Other therapies that are also of interest are the ADCs. Again, we heard about this in ovarian cancer as well. These are two trials that were recently presented at ESMO in Madrid. The first on the left is luveltamab tazevibulin, which is a folate receptor alpha targeting ADC. And we heard about the data in ovarian cancer, and there seems to be preliminary efficacy in endometrial cancer. That would be nice to explore in a later phase study. On the right, we've all talked about trastuzumab deruxtecan in both ovarian and cervical, and similar to those disease sites, we see in endometrial cancer that the objective response rate was 57% in 40 patients, and similar to the data that Leslie showed about the efficacy in the +3, which is the red line on top, and the first curve is all cohorts. You can see that the PFS was improved when compared to 2+, and then similarly on the bottom is the endometrial cancer cohort of 40 patients, where you see the red line, which is the 3+, had improved PFS. Again, I think we need to keep all of this data, as exploratory. It's really interesting, and hopefully we will tease this out in our future phase 3 trials.
Can I mention something with
Yeah.
trastuzumab deruxtecan? I mean, 84.6%. Oh my gosh, that is like
That's 13 patients. I just need to
I
point
know,
that out.
I know, but it's 13 patients, but wow, I mean, that's
Yeah.
crazy. And I will tell you, people are utilizing this. This is NCCN guideline approved. And I've heard a few stories at our centers, as well as from other colleagues, that patients who've been previously treated with trastuzumab, then have a recurrence, are
Oh, yeah.
responding to this
Yeah.
drug.
Oh, yeah.
So I know it's a small number of patients, but I'm very excited about this. Even if you look at all patients, that response rate in 40, 57.5%, I mean, this is really exciting stuff.
Yeah, these were
I've had
fairly
several-
heavily pretreated patients, period. Not just.
Some small numbers, but much more common than cervix cancer.
Yeah, right, the expression, yeah.
Cervix we may not see that many, but here we're going to see patients, 20 to 30%.
Yeah, like squamous is under, and cervix is under 5%.
Yeah, yeah.
6%.
And I've used these HER2 ADCs, and there have been patients who I was going to put on hospice that I've rescued and have had prolonged responses. So these are game changers.
That's for sure.
Yeah. And on the bottom, I just have here that this is NCCN listed as of September 20th. So for +2 or 3+. Yep. So the only phase 3 ADC that we have is GOG 3095. And Dr. Monk, since you're leading this, do you want to tell us about it?
Leading it for the GOG, Keta LaRusso is leading it for the world. So, and I share your enthusiasm for HER2, but don't forget TROP2, okay? So hats off to Santine, Alessandro Santine from Yale. He's presented now 2 papers on ADC TROP2 sacituzumab, which Gilead. 2 studies in IAT with 21 patients, 33% response rate. Tropics 3, which was a little better, had 41 patients, but went down to 22%. So the response rate of TROP2 at 22, 23%, but the DOR, the duration of response in the Tropics 3 was 8 months, and the clinical benefit rate, as defined as 6 months of progression-free, was back up above 30%. So you got, again, same guy, same agent, 2 studies, so we're going to roll. Now, there are 4 TROP2s in the clinic in endometrial cancer. I just said sacituzumab. The second is SKB264, which is this molecule, 2870. That was a Kellen molecule that was acquired from Merck last December. That's number 2. That's what this is. IO exposed, okay, versus the same control arm of 775, okay? The third one is datopotamab, deruxtecan, same payload as trastuzumab deruxtecan, but TROP2, also AstraZeneca, okay? You'll see it in lung get approved undoubtedly. That's also been studied in endometrial cancer. And then an agent that you're very excited about, which is DB1305, which is the duality TROP. So you got 4 of them. This is the first phase 3 trial. And so we have now, we're near completion of site selection. So if you're still thinking about opening it, let's get ready here. 710 patients randomized 1-to-1, IO exposed. So the question is, what do you do after Ruby, all comer, as I said?
Yeah.
You put them on this trial, and also heads up for HER2. So these are the 2 leading ADCs, HER2 and TROP2.
Yeah, I think this is really exciting because this is the first phase 3 ADC trial in endometrial cancer.
We're trying to keep up with, Katie Moore and others, with Merv and Brian and others with tisotumab vedotin and cervix. So we're trying.
Thanks for that, Brett. Last but not least, hormonal therapy. Let's not forget about hormonal therapy.
Fine.
We have to remember that the first FDA-approved agent in endometrial cancer was progestin. That's the good news. The bad news, it was in 1973, I think. So we needed to do more work. Upper left, I don't want to go through these numbers. Active agents, single agent hormonal therapy, tamoxifen, megestrol, progestin alternating with tamoxifen, and anastrozole, letrozole, and leuprolide, all with some activity, and we see some of the activity there. Obviously, we saw more with the ER-positive tumors, and the PR-positive tumors than the ER-negative tumors, but good activity, but not great. And then what we've done over time is combining them with biomarker-driven therapy. I always say endometrial cancer researchers were not that smart. We just need to borrow some ideas from breast cancer, and we did that here. Bottom right, GO3007, based on work that Rob and I had started when I was at MD Anderson. First we looked at single agent, everolimus, an mTOR inhibitor. Then we combined it with letrozole. And I want to highlight here, look at in the chemo-naive patients. Again, maybe giving these agents prior to chemotherapy. Chemo-naive patients, PFS of 28 months. In that study, we compared it to progestin, tamoxifen, 5 months. Now go back to the first slide we presented, 209, which is the standard of care. This doubled. Can't do cross-trial comparison, Dr. Monk, I get it. But this doubled the PFS in the chemo-naive patients. Obviously an area that we need to move forward. CDK4/6 inhibitors as well. Dr. Mirza in the NGOT study looked at palbociclib and letrozole versus letrozole placebo. Progression-free survival, 8.3 months versus 3 months. I want to highlight these are cytostatic agents. You can't look at response rate. You need to look at progression-free survival either at 6 months or head-to-head progression-free survival. We saw the difference here. Really exciting agent, something that we want to really not take out of our armamentarium. And I know Dr. Pathouri is very much interested in future trials looking at the CDK4/6 pathway. A couple minutes here to discuss, before we go to the summary slide, a couple of minutes here to discuss non-IO second line. Ritu, start out with you. What are some of your ideas on some of these agents, and how excited are you? ADCs. ADCs.
I mean, I'm super excited. I think this has just been revolutionary. So I think looking at the biomarker expression, TROP2 doesn't really require it. It seems like it's pretty universally expressed, or maybe not represented. But HER2 is really exciting. The TROP2 is really exciting, and I'm curious to see what the IO after IO data. But I think that on clinical trial it makes a lot of good sense. I am excited about selinexor and navtemadlin in the P53 wild type. So I think there's lots of opportunities here, and getting these patients and understanding how we sequence these, what's best for what patients, is really important to me.
Now, Angeles, you have one of the largest, really, registries, data collections looking at biomarker-driven therapies in endometrial cancer. You mentioned earlier you're so passionate about this. Talk to us how it's going to affect your practice in endometrial cancer based on some of these trials.
Yeah, I mean, it goes back to NGS testing, so next-gen sequencing on anybody who has a recurrence, and then I think it's totally acceptable to do in the frontline setting as well. So right now, I just love the opportunity to do data mining and identifying new prognostic and potentially predictive biomarkers.
Bhavna, you're passionate about not only the ADCs, but as mentioned, some of the hormonal-driven pathways with CDK4/6. Some of your thoughts?
I'm passionate about all of these new therapies, honestly, because we need better treatments for these patients. after they progress after frontline therapy. And so having ADCs, having hormonal therapies, having our biomarkers to help us guide therapies, I think all of these will help our patients in the clinic. And, you know, I do want to stress that as we think about these trials, it is so important, as Angela's pointed out, that we include patients from underrepresented populations. And, you know, 4% is not acceptable, Angeles, especially in a disease where Black women have twice the mortality of white women and where these therapies are really important. So I just want to, you know, I'm really happy that the GOG has made a real commitment to this. I'm happy that many of the pharma companies are also committed to this, and of course, having the FDA require a diversity plan also helps us improve this as we continue to design trials and enroll more patients that are representative of the population expected to use the medicine.
Well said.
Rob, we've given people the last word on endometrial cancer, the excitement here. What is your thoughts?
Screen early and screen often. I think what's been said here, I completely, obviously, am very vehemently supportive of. I think we've changed this paradigm of histology to one of molecular characterization, and we're, I think, really at the beginning of this story, and it's going to continue to evolve, and we're really fortunate to have partners in our that are like the ones supporting this conference to help us along the way to move these assets into earlier lines therapy.
Yeah. Summary slide here. We already went over it. DMMR, checkpoint, PMMR, checkpoint, opportunity for clinical research, IO after IO. Rita, you just mentioned that again, and Bhavna did a nice review of non-IO treatment options.
And I just want to make one more plug that we're going to have an idea symposium at the Winter NRG. It's going to be the educational symposium where we really focus on how we can all work together to improve idea in clinical trials.
That's good. The Winter NRG, she's had a lot of meetings with the Winter NRG. I think it's open for registration now.
Yeah.
So I think
and there's a nice manuscript, right, Bhavna?
Yeah, we have a nice manuscript also which can serve as a roadmap to help as people are trying to look at ways to improve diverse patient accrual.
No, that's great. And like I say at all of our meetings, thanks for giving me the opportunity to talk about endometrial cancer. I appreciate it, and I look forward to future studies.
Your time is up.
Yeah.
as it usually is.
And just says, okay, we'll move on.
Thanks, guys.
So that's what you guys can do together. I want to thank the group. Tom, you have the last word.
Yeah, well, I've got a few words, so thank you. So first of all, we do have a minute or two. Literally in just a word or two, can you tell us what you're most excited about? And you can do a shameless plug for a future meeting or whatever you want to do. Sue?
Well, I'm going to go with cervix. That's near and dear to my heart. And I'm just really excited about, you know, what's already happened in cervix, but really what's next. And, you know, some of it's still kind of in development, but we have a trial that's looking at HPV vaccine target with atezolizumab that I'm really excited about. Trials, you know, site selection's being done, and it's going to be active hopefully soon. So I think that's something to keep your eye on. We're really excited about the progress, but there's a lot more to do.
Great. Rob?
I'm going to do a shameless plug for Export EC because I think that P53 question hopefully will get addressed, positive or negatively, but it'll be addressed there, and I think that's a real opportunity.
Yeah, and you love the MOA. And,
yeah.
Similar interest in CARTOS. Everyone should have one of those open.
Yeah, absolutely.
Yeah. Okay, good.
I'm focused on mission, vision. Vision here is transforming gynecologic cancer care. Vision, some of our other organizations, is eradicating gynecologic cancers. And I'm going to do a shameless plug for our SGO annual meeting in 2024 because we're going to actually have more information there. And we are on our way to making a huge difference in patients' lives with gynecologic cancer. And it's just, the sky's the limit. Let's keep crashing through the glass ceilings.
Yeah, love it. Bhavna?
I think I've said this at a previous highlight reel, but I think it's all about biomarkers, and we're learning that it's so important to test all disease sites with NGS, and our therapeutic opportunities increase as we have those results and pay attention to them, and we're able to offer our patients these targeted therapies.
Great. Brian, no time. All right. Go ahead.
So regardless if it's endometrial cancer, which is what I'm focused on, cervical cancer, ovarian cancer, whether regardless first line or second line, getting rid of chemotherapy, sometimes ineffective chemotherapy, and looking towards whether it be ADCs, hormonal therapies, checkpoint inhibitors, without the chemotherapy, identifying, to Bobna's point, using the biomarkers to identify those patients that we can eliminate chemotherapy. Thanks.
All right. So, Brad, I want to thank you. Great job co-moderating and all that you've done for our patients. What I'm really excited about is some of the collaborations we've been able to do this year with other organizations. I'm really excited about the energy side of our foundation. I'm excited about partners. And I'm really excited about the dedication that all of you, the investigators, continue to show, both for energy trials and for GOG partner trials. We can't do this without you. It means so much to our patients, so thank you from the bottom of my heart. I want to thank my team. Tremendous panel tonight. Thank you. Tremendous co-moderating. I also want to thank our commercial supporters, AstraZeneca, GSK, again, Seagen, Genmab, Immunogen, Genelux, Acrivon, and our farm. Brad, did you have a word?
So I just wanted to look to the future. So everything that we've said is amazing, and thank you. Everything that you've done is amazing. We have had at least 6 trials of immune therapy in ovarian cancer that have failed. We've heard wonderful data in cervical and endometrial cancer that have not failed. And we're prepared to make our last stand in ovarian cancer by adding PARP inhibitors to IO. And so stay tuned. We'll join you again for number 7. But we have Athena combo, we have FIRST, and we have KeyLink, hopefully evolving what you said, Tom, the frontline treatment. And if we can add IO to PARP in the front line, that will really change the standard of care and hopefully cure more patients with ovarian cancer. So we've taken our last stand.
Yeah. So real quickly, we're going to move this program to the highlight reel. Will take place on Saturday after the energy meeting, our semi-annual meeting. So it'll be on Saturday. We'd love to have many of you join us live is what we're going to aim for, which would be great. And so the next one will be in July of 2024, and we look forward to all of you join us. More information can be found about this upcoming program on our website at www.gog.org. You can also see us on our YouTube channel, so lots coming on there. If you would please fill out your evaluation. It's for 2 reasons. One, to help us get better, because obviously we need to. Speaking for myself. And we also, you will need it to get your CME credits. So you'll get up to 2.5 credits for tonight's session. And if you want to watch it again, you can find it at our website or our YouTube channel. So we're excited about that. You can follow us on Twitter, Facebook, LinkedIn, Instagram, X, pretty much anything, as you know. I want to wish everyone a great evening and a happy holiday season. And again, thank you for joining us.